Seats. The subcommittee will come to order, and I will recognize myself 5 minutes for an opening statement. Today, we're here to discuss legislation to promote access to care and improve health outcomes for Americans. We will consider bills to help support innovation for therapies and life-saving cures for rare diseases which affect more than 30 million Americans. That is why we are considering H.R. 3391, the Gabriella Miller Kids First Research Act 2.0, which would reauthorize the National Institutes of Health Gabriella Miller Kids First Pediatric Research Program. We're also considering H.R. 3226, the PREEMIE Reauthorization led by Ranking Member Eshoo and Representative Miller Meeks, Kelly, Kiggins, Blunt, Rochester, and Burgess. We are also have more work to do to protect the long-term health and well-being of expecting and new moms. We will consider to build off this work the subcommittee has done over the past several years to address maternal mortality. H.R. 3838, the Preventing Maternal Deaths Reauthorization Act, will continue the work done by the CDC and the Health Resources and Service Administration, HRSA, to provide access to resources for women experiencing risky pregnancies and develop best practices to treat at-risk moms. We're also considering H.R. 3821, the Firefighter Cancer Registry Reauthorization Act. Our first responders experience adverse health outcomes, often resulting from selfless and brave work they do to keep us and our loved ones safe. We're also considering legislation to advance our knowledge of rare diseases and promote access to therapies to treat rare diseases such as sickle cell and Parkinson's disease. As a step forward to address the issues today, we are examining H.R. 3884, the Sickle Cell Disease and Other Heritable Blood Disorders Research Surveillance Prevention and Treatment Act, and H.R. 2365, the National Plan to End Parkinson's Act. I would like to thank Representatives Burgess and Bilirakis for their leadership on these bills. And fortunately, as we have these breakthroughs, we absolutely need to make sure that people have access to them. And so we have that we had in the hearing last week, the MVP bill, that hopefully we can all come together to make sure that the least of us have access to these life-saving therapies through the Medicaid program. And last, we're considering H.R. 3887, the Children's Hospital GME Support Reauthorization Act of 2023. This program provides funding to children's hospitals to help train resident physicians and dentists. It is critical for us to reauthorize the program before the end of the fiscal year with the necessary policy changes to keep kids safe from experimental procedures. In closing, I'm proud that these bipartisan bills before us will improve access to care and drive innovation. Patients and their families will be better off because of the work we're doing today, and I will yield my remaining time to Dr. Burgess.
And I thank the chair for the recognition. So it is so important that we're considering the reauthorization of the PREEMIE Act, introduced by my good friends Anna Eshoo and Marinette Miller Meeks, along with several other members. The PREEMIE Act would reauthorize programs that expand research, education, and intervention activities aimed at reducing premature birth and treating the complications of prematurity. You know, we're just a few weeks away from the 60th anniversary of the birth of the last child in the White House. Patrick Kennedy was born August 7th, 1963. Unfortunately, he did not live too long because of complications of prematurity. And indeed, his father, the President of the United States, tried to enlist help from all sectors in the medical community in order to save his son, but he was unsuccessful. Writing in his great book, William Manchester, in detailing the life and death of President Kennedy, he talked about that trip to Dallas, and the day before the trip to Dallas, the president was in San Antonio. In San Antonio, he was shown an experiment that was going on regarding high-altitude physiology. There were 4 men in a container, and they were being simulated 30,000 feet, and they were being given high oxygen. The president pulled the investigator aside, and according to Mr. Manchester's book, he drew Dr. Welch aside. He had one more inquiry. Apart from space research, there must be other medical implications here. Do you think your work might improve oxygen chambers for, say, premature babies? Clearly, his experience was very much on his mind that day. Very personal to me because 13 years later, in August of 1976, my daughter was born a few weeks early and suffered from the same complications: idiopathic or infantile respiratory distress syndrome, hyaline membrane disease. And because of the work that had occurred over those intervening 13 years, the science of neonatology, the specialty of neonatology, had come into being, and neonatal intensive care units had now occurred. So because of those efforts, my daughter, 13 years later, short stay in the hospital, take your medicines, do your treatments, and you live a normal, healthy life. That's the kind of work we're talking about today. That's the type of work we're reauthorizing. I thank my friends for introducing it. This is important work as we go forward. I'll yield back.
Thank you. Thank you for your story. The gentleman yields back, and I will yield back the time. And I now recognize the gentlelady from California, Representative Eshoo, for 5 minutes for an opening statement.
Thank you, Mr. Chairman, and good morning, colleagues, and thank you to this sterling full table of witnesses that we have with us today. Today, we're considering 8 proposals that increase access to care and reauthorize critical public health programs, and 1 proposal that does exactly the opposite. I'm pleased that my legislation, H.R. 3226, the PREEMIE Reauthorization Act, is included in the hearing, and I thank my co-leads, Representatives Miller Meeks, Kelly, Burgess, Blunt Rochester, and Kiggins, for their work on this important effort. In 2005, I introduced the original PREEMIE Act with former chairman of our full committee, Fred Upton, which was the first and remains the only law to focus solely on the prevention of preterm births. We need a swift reauthorization to ensure the successful programs created by this law can continue. 3226 will also improve future policy by studying the current gaps in our healthcare system that have led to the recent surge in preterm births and how we can address them. Excuse me. Our hearing will also consider critical bipartisan bills, such as the Preventing Maternal Deaths Reauthorization Act, the National Plan to End Parkinson's Disease, and the Firefighter Cancer Registry Reauthorization Act. I see Kevin nodding there. But we're also considering a proposal that will damage the Children's Hospital's graduate medical education program irreparably by making hospitals choose between providing the standard care for children experiencing gender dysphoria or losing funding that keeps them afloat. There should not be a choice here. It should not be one or the other. For nearly 25 years, the CHGME program has trained half of general pediatricians and a majority of pediatric specialists. In California, CHGME program funds are used by 7 children's hospitals to train over 906 full-time pediatric residents annually. This is an extraordinary record. It's an extraordinary record, something that we are proud of on both sides of the aisle because it has had the full support of members of both sides of the aisle. And that's why it's difficult for me to comprehend why my Republican colleagues are subjecting the children's hospitals to a manufactured culture war that puts politics in between parents, children, and their pediatricians. This just shouldn't be here. It just shouldn't be here. Specifically, the bill prohibits 19 specific procedures and any type of hormone therapy that could be perceived as gender-affirming for trans youth. This proposal threatens precious lives. It's not just a bunch of words on a piece of paper. As one pediatric endocrinologist said, every time politics and medicine commingle, people die. We're already seeing higher rates of maternal and infant death because of abortion restrictions that paralyze providers in an emergency. Now Republicans are attempting to ban 19 more procedures and treatments that should be a private decision between patients, their families, and their doctors. This proposal also worsens the mental health crisis that trans children are facing. This is really sad, and if I had a magic wand, I would just wish this away. But it's something that's before the committee today. I want to close on this with this quote. I was watching the news one night, and there was a Nebraska lawmaker, an independent, a woman, a mother, and this is what she said. I'm asking you to love your family more than you hate mine. I hope that this issue will somehow not make it here. This doesn't belong here. We follow science. We have worked on a bipartisan basis to build and build and build across our healthcare system. So much of the decision-making is private. That's where it belongs. So thank you to our panel of experts that are here today, and I yield back.
The gentlelady yields back, and the chair now recognizes the chair of the full committee, Chair Rogers, for 5 minutes for an opening statement.
Today's hearing looks at key programs that aim to improve access to care and support research for rare diseases. This includes solutions to help save the lives of mothers and babies, improve our understanding of blood disorders, coordinate federal efforts related to Parkinson's disease, and ensure we are appropriately monitoring instances of cancer and firefighters so that we can get these heroes better treatments and care. I look forward to hearing from our witnesses about the effectiveness of these programs. As part of our work to help mothers and babies at every stage of life, we are continuing our work to reauthorize the PREEMIE and Preventing Maternal Deaths program. Especially for first-time moms, I think about the joy and also the uncertainty, the questions, and all that comes with being pregnant. Across the country, there is a need for stable and consistent resources and education around maternal health. That is why I was pleased to see the Preventing Maternal Deaths reauthorization included a requirement for CDC and HRSA to share best practices to hospitals and other healthcare entities to ensure we are doing everything we can for moms, babies, and families to thrive. I hear often from constituents not knowing where to turn when dealing with postpartum depression in rural areas. HRSA has a national maternal mental health hotline, but getting best practices to doctors on how to best help women will hopefully lead to improvements in maternal mental health. We are also considering the reauthorization of the Children's Hospital Graduate Medical Education Program. In nearly 60 hospitals across the country, this program helps train our next generation of pediatricians. As we discuss other solutions today, like the Gabriella Miller Kids First Research Act, I imagine moms and dads who hear the diagnosis no parent wants to hear from a doctor. Your child has cancer. And then, for the love of their child, the parents pour themselves into making sure that their child will have the best chance to one day achieve their hopes and dreams. From our work on this committee, we know all families have experienced this. That is why we must authorize the Children's Hospital Program, so America's children are cared for by the best doctors in the world, doctors who we trust to practice with the strongest medicine, data, and science, so our kids live full, happy, and healthy lives. We are not shying away from the concerns that children are being rushed to experimental medical interventions that could include puberty blockers, hormone therapies, and surgeries that cause irreversible damage. Dr. Miriam Grossman is here today to share the data and why other countries are stepping back from these interventions for children because of the risk, like permanent infertility, outweigh the benefits. Our children's hospitals and medical institutions should also be urging caution and being honest about where the evidence is lacking. Many times on this committee, we've come together to protect the young generation. I've had many conversations with my colleagues about our concern for teenage girls in particular, who are facing more stress, anxiety, and pressure than ever before. For them and children in crisis, we have taken historic action on mental health care reforms. We are leading right now to stop big tech's algorithms from manipulating children and preying on their vulnerabilities. And this work must continue. And we need to do everything we can to stand up and protect children. That is our goal today. Let's send a message to the young generation that they are loved as they are. And let's make sure that we're getting the best health care possible. They deserve nothing less. To close, I want to thank my colleagues who are leading on solutions we are discussing. Thank you to our witnesses for your time and providing your expertise this morning. We are grateful on this committee, and this committee is about doing the hard work, plowing the hard ground necessary to legislate and to improve the lives of those that we serve. I look forward to the discussion, and I yield back.
The chair yields back. The chair now recognizes the ranking member from New Jersey, the gentleman from New Jersey, Rep. Pallone, for 5 minutes for an opening statement.
Thank you, Mr. Chairman. Today could have been a bipartisan hearing, but once again, Republicans are playing political games with the health care of Americans. And I'm deeply disappointed with the legislation that Republicans are bringing up for consideration today to reauthorize the Children's Hospital Graduate Medical Education Program. This unnecessary and discriminatory bill is going to dominate this hearing, which is unfortunate since there are bipartisan public health policies that we should also be discussing here today. The CHGME program is a longstanding effort to support the training of pediatricians and ensure that children across the country have proper access to care. And this is a popular program. Since its inception, it has consistently received strong bipartisan support. In fact, reauthorization of CHGME has always been done in a bipartisan manner. Today, we should be considering legislation introduced by my colleague, Representative Schreier, that is bipartisan reauthorization of this important program. But instead, Republicans have chosen to notice a partisan bill that includes language to ban medically necessary care for transgender youth. Now, the Republican bill goes against decades of scientific research and evidence that has established clear standards of care that is effective and essential to the health and well-being of transgender youth, care that is supported by the American Academy of Pediatrics, the American Medical Association, and every other leading medical association. Banning evidence-based care is an affront to science, and it is dangerous. So let me be clear about what is happening here. Republicans want to prescribe in excruciating detail in federal legislation which medical treatments and care are acceptable to provide to young people. They're trying to overrule doctors, patients, and their parents. We know that transgender youth are already vulnerable to mental health challenges. Nearly 1 in 5 transgender and non-binary youth have attempted suicide, and nearly half have seriously considered suicide in the past year. This is staggering, and Republican attempts to deny necessary medical care only puts them at greater risk. We know that providing care decreases suicide risk. We should be supporting and affirming transgender young people for who they are. This Republican ban also restricts options and disregards parental rights. They are telling parents that Republican politicians know better than they do what is best for their child. And this is the height of hypocrisy from a group that supposedly believes in limited government. Not only is this ban an attack on transgender youth and their parents, but it is also an attack on doctors and other healthcare providers. It would prohibit any CHGME funding if a hospital or training program performs this important care. This would cripple the funding mechanism that trains over half of all pediatricians in the United States. Children's hospitals would be forced to make a choice between providing medically necessary care for their patients or foregoing federal funding dedicated to the training of their residents. By attacking providers and their training, Republicans are trying to dismantle medical education, research, and care for all children and adolescents. So it's quite simple. Republicans should stay out of the doctor's office. That's what I recommend. Stay out of the doctor's office. And with that, Mr. Chairman, I yield back.
The gentleman yields back. That concludes opening statements. We will now move to witnesses' statements. And I'll just let you know, as you've tested, some of you testified here before, you have 5 minutes. There'll be a green light in front of you. You'll see that. It'll turn yellow within a minute, and so that's time to start wrapping up if you haven't moved forward, if you haven't at the time, and then when it turns red, the time's expired. So I will begin by introducing all of our witnesses, and I'll call on you one by one to give your opening statement. Our witnesses today are Dr. Elizabeth Shiro, Senior Vice President and Chief Medical Officer for the March of Dimes, Dr. Alexis Thompson, Chief of the Division of Hematology and Elias Schwartz Endowed Chair in Hematology at the Children's Hospital of Philadelphia and Professor of Pediatrics at the University of Pennsylvania Perelman School of Medicine, Dr. Meredith McNamara, Assistant Professor at the Yale School of Medicine, Dr. Miriam Grossman, Child, Adolescent, and Adult Psychiatrist, Mr. George Manahan, Child, Adolescent, and Adult, Parkinson's Advocate and Patient, and Mr. Kevin O'Connor, Assistant to the General President for Governmental Affairs and Political Action for the International Association of Firefighters. Dr. Shiro, you are recognized for 5 minutes for your opening statement.
Good morning, Chairman Guthrie, Ranking Member Eshoo, members of the Health Subcommittee. My name is Dr. Elizabeth Shiro. I am Senior Vice President and Chief Medical and Health Officer at March of Dimes, the leading organization fighting for the health of all moms and babies. Our work today is more important than ever, with the nation in the midst of a dire maternal and infant health crisis. By improving the health of women before, during, and between pregnancies, we can improve outcomes for them and their infants. But we have many challenges. Recently, the CDC released its 2021 maternity mortality rates report, which showed an increase of nearly 89% in the maternal mortality rate since 2018. At the same time, the number of women who experience pregnancy-related complications or severe maternal morbidity is increasing at a troubling rate. The state of infant health mirrors that of maternal health. While the most recent preliminary 2022 CDC data on preterm birth shows a 1% decline in preterm birth rates, 1 in 10 babies are still born too sick and too soon. This small decrease, while promising, only highlights the need to redouble our efforts. What's more persistent, racial disparities exist. Black and Native American women are 62% more likely to give birth prematurely, and their babies have a mortality rate double that of the white population. Let me share one of the stories from my full testimony that exemplifies the experiences faced by mothers who deliver their babies prematurely. Katie Wilton of Phoenix, Arizona, began facing life-threatening complications 22 weeks into her pregnancy when she began hemorrhaging. During the next 8 weeks, she suffered 2 more bleeding episodes, and at 29 weeks and 2 days, Katie found herself in preterm labor. When she arrived at the hospital, she was given treatment to slow her labor and prepare for Colette's early arrival. As Katie was soon to learn, she was experiencing chronic placental abruption, where the placenta prematurely separates from the uterine wall. When Colette was born at exactly 30 weeks gestation, she was diagnosed with severe intrauterine growth restriction. She weighed only 3 pounds, 1 ounce, and measured a mere 14 inches long. During her 63-day stay in the neonatal intensive care unit, Colette was given life-saving medication. Among them was surfactant therapy, a treatment to advance lung development, which was developed by the March of Dimes funded research. This story and hundreds of thousands of others each year, just like it, highlights the need for us to do more. To that end, March of Dimes supports the following legislation being considered by the subcommittee today: H.R. 3226, the PREEMIE Reauthorization Act of 2023, which represents the federal government's commitment to preventing preterm birth and its consequences. This legislation specifically reauthorizes CDC's highly successful Pregnancy Risk Assessment Monitoring System, or PRAMS. PRAMS collects site-specific population-based data in 50 jurisdictions, tracking maternal attitudes and experiences before, during, and shortly after pregnancy. The Act also reauthorizes the Health Resources Services Administration's HRSA's activities aimed at promoting healthy pregnancies and preventing preterm birth, and it provides a new study by the National Academies of Sciences, Engineering, and Medicine, which will examine the societal costs, the impact of societal factors, and gaps in public health programs related to preterm birth. March of Dimes also supports H.R. 3838, the Preventing Maternal Deaths Reauthorization Act of 2023, which strengthens and expands federal support for the Maternal Mortality Review Committees, MMRCs, established under the authorizing law enacted in 2018. MMRCs play an invaluable role in identifying maternal deaths, analyzing the factors that contributed to maternal deaths, and translating the lessons learned into policy. They have revealed that cardiac-related issues are the leading cause of deaths for mothers, and that the majority of deaths do not occur during childbirth, but in days and weeks after. This legislation would continue to disseminate best practices and help MMRCs promote the case review process. Thank you for focusing your attention on these two public health crises. March of Dimes stands ready to work with you to enact this critical legislation.
Thank you for your testimony. The chair now recognizes Dr. Thompson for 5 minutes for her opening statement.
Chairman Guthrie, Ranking Member Eshoo, and the distinguished members of the committee, thank you for the opportunity to participate in this hearing to discuss H.R. 3884, the Sickle Cell Disease and Other Heritable Blood Disorders Research, Surveillance, Prevention, and Treatment Act of 2023, and the importance of this reauthorization to federal efforts to improve the lives of the nearly 100,000 Americans living with sickle cell disease. This legislation is critical to support access to care for patients with sickle cell and related disorders. With early diagnosis, which is often achieved through universal newborn screening in this country, effective evidence-based interventions can be introduced that will save lives and reduce suffering. My name is Dr. Alexis Thompson. I am the Chief of the Division of Hematology and the Schwartz Endowed Chair in Hematology at the Children's Hospital of Philadelphia and Professor of Pediatrics at the University of Pennsylvania Perelman School of Medicine. In these roles, I treat children and adults with sickle cell disease. I educate future clinicians about sickle cell disease and comprehensive care, and I lead a research team engaged in innovations in sickle cell and other blood disorders, such as gene therapy as potential cures. I've also served as president of the American Society of Hematology, which is the largest professional society serving both clinicians and scientists who are working to conquer blood disorders. Since the initial authorization of the Sickle Cell Disease Treatment Demonstration Program, HRSA has provided important resources for education and training to improve access to quality care for patients living with sickle cell disease and also those with sickle cell trait. This program addresses an important recommendation that comes from the National Academy of Sciences, Engineering, and Medicine report addressing sickle cell disease and strategic plan and blueprint for action. H.R. 3884 will authorize the sickle cell demonstration programs through fiscal year 2028 and will allow the agency to build upon its efforts and the investment that has been made thus far. This program will increase the number of clinicians who are knowledgeable about sickle cell disease care, improve quality of care provided for individuals, improve care coordination, and to disseminate best practices for the coordination of services, particularly during the critical pediatric to adult transition. This particular program is designed to be a regional approach and currently now covers the entire United States. One example of how this program is effective is its use of the Project ECHO model, which allows providers to have increased confidence in treating sickle cell patients by being able to interface with experts in sickle cell disease, many of whom are located some geographic distance from their practices. By establishing a regional sickle cell disease infrastructure, the program partners with states to develop and support comprehensive sickle cell care programs that deliver care across the lifespan and implements telemedicine or telehealth technologies in order to do so. It covers the entire country and it utilizes a regional hub-and-spoke model, and this has been particularly successful in the current funding cycle, particularly when individual providers are some distance from academic medical centers. I also urge, in addition to H.R. 3884, I urge the committee to consider how to improve the program, in particular, providing more resources for measurement or metrics. We know that measurement is critical to understand and to quantify increases in certain sickle cell complications, which frankly are preventable with comprehensive care. Additionally, will allow us to expand and to identify unaffiliated patients who truly are receiving inadequate and, to best of our knowledge, in some cases, no care. We would also encourage Congress to invest further in the CDC's sickle cell disease or data collection program, which complements the HRSA effort by utilizing its strengths in surveillance to be able to provide necessary information, metrics, to help us to understand where sickle cell patients live, their current quality of life, and how we can continue to intervene. There are currently only 11 states who are currently participating in this program. It only represents about 35% of sickle cell patients. We think that there also needs to be continued congressional support for this vital program. We also would also encourage the committee to consider supporting H.R. 1672, the Sickle Cell Disease Comprehensive Care Act, which would direct the Centers for Medicare and Medicaid Services to provide funds to create demonstration programs to look at access to comprehensive care and high-quality outpatient care for individuals who are enrolled in Medicaid. We believe that these are key federal investments for improving the health of individuals with sickle cell. The sickle cell community is deeply appreciative of this committee and the Congress for their ongoing commitment to address sickle cell through these programs. Again, I urge this committee to act now and to reauthorize H.R. 3884. Thank you for the opportunity to testify before you.
Thank you for your testimony. The chair now recognizes Dr. McNamara for 5 minutes for your opening statement.
Thank you, Thank you, Health Subcommittee Chair Guthrie, Ranking Member Issue, and members of the subcommittee. I'm a board-certified pediatrician and a specialist in adolescent and young adult health. I've spent 12 years in medical training and direct patient care and in clinical research. I'm honored to serve the diverse needs of young adults aged 12 to 25, and as an assistant professor at the Yale School of Medicine, I teach medical residents, students, and fellows. I am also the co-founder of the Integrity Project for Child and Adolescent Health, which seeks to infuse health policy debate with scientific evidence. My testimony today reflects my academic and clinical work, as well as medical consensus, and not the views of my employer. The amendment to the Public Service Act before you proposes to defund pediatrics training programs throughout our country if these institutions provide the standard of care to transgender youth. I'm honored to speak here today on behalf of esteemed colleagues throughout the nation who provide this best practice medical care for children and youth, including trans youth and their families. As a physician with a commitment to patient care, I'm honored to be able to do more for them here than I can do in the office. The past few years mark a rapidly shifting and hostile political climate towards medical care for transgender people with a harsh focus on youth. Care that should be a private matter for families, patients, and providers is now being directed by legislators based on unsupported fears and misinformation. I understand that this care may be confusing to those who are not medical providers with expertise in treating this population, or those who do not have a personal connection to a transgender person. That is why it is critical that this body base its decisions on facts and accurate information. Most of us here would not disagree with that. From my position as a medical practitioner and a member of a large community of experts in this care, I see 5 categories of misinformation. Denial of the medical condition of gender dysphoria, false claims about standard practice, false claims about the evidence that backs care, false claims about the safety of treatments, and an attack on medical authority. And I'm here to ensure that you have the facts to address this misinformation. Gender dysphoria, the long-standing and significant distress that many transgender people have from the incongruence between their gender identity and the sex they have at birth, is real. It's a recognized and serious medical condition. Transgender people of all ages exist. Their healthcare is based on established standards of care and clinical practice guidelines, which are themselves based on substantial medical research and evidence, as well as decades of clinical practice. Based on these standards, youth and parents receive informed counseling about the risks and the benefits of specific treatments, and every major medical organization has endorsed this care. As a pediatrician, I must also address the proposed amendment. Pediatrics residencies and fellowships are the backbone of healthcare for children in this country. During the triple-demic of influenza, COVID-19, and respiratory syncytial virus, also called RSV, it was pediatrics residents and fellows who worked every hour of every day to help children survive life-threatening respiratory diseases. They help NICU babies get to kindergarten. They keep outpatient clinics flowing so that kids get routine well care. Residents and fellows form a pipeline of research and innovation that makes this country a global leader in every area of pediatric medical science. This bill would require children's hospitals to deny kids health care to maintain funding. As a practical matter, there is no way to banish all transgender youth from children's hospitals, nor is there a way for pediatricians to simply refuse to provide these youth with medically necessary care. All kids suffer when their legislators remove parents' rights and prevent pediatricians from providing this standard of care. And I have to tell you, American pediatricians will not accept being told that they have to leave even a single child behind. There's no room for There's no room in our clinics for the government. I had a conversation with a trans teen recently. Gender dysphoria began early in puberty and worsened as puberty progressed. The parents sought and received help. This family asked me to tell members of this committee that gender-affirming care gave their kid confidence. This teen stands tall, debates international law and model UN sessions, recently in this city, our capital, to compete in nationals. This care was life-saving, life-affirming. College options are limited to states that protect trans healthcare, but even still, this teen is excited for the future that lies ahead. That's what every kid in this country deserves. Please don't make it harder for us pediatricians to get them there.
Thank you. Thank you for your testimony. The chair now recognizes Dr. Grossman for 5 minutes for your opening statement.
Thank you, Chairman Guthrie. Chairman Guthrie and members of the subcommittee, thank you for the opportunity to address you. My name is Miriam Grossman. I am a board-certified child, adolescent, and adult psychiatrist, author, and senior fellow at Do No Harm. I have been taking care of patients for 45 years. I'm going to use my time to respond to Dr. McNamara. First, I'm struck by her use of the phrase, sex assigned at birth. Sex is not assigned at birth. Sex is established at conception, and it's recognized at birth, if not earlier. Dr. McNamara claims that her views are science-based, but to claim that sex is assigned at birth is without any scientific basis whatsoever. Its language misleads people, especially children, into thinking that male and female are arbitrary designations and can change. That is simply not true. Dr. McNamara claims that social and medical interventions are the only evidence-based treatment and that scientific evidence shows it is life-saving. Without it, she's warning us, kids will commit suicide. Well, a growing number of countries have effectively banned the care to which she's referring. And thank God there's been no wave of suicides or other mental health catastrophes. 3 years ago, Finland placed strict limitations on medical interventions for minors. Sweden did the same thing after a 14-year-old girl was found to have osteoporosis and spinal fractures from puberty blockers. An investigation concluded, quote, the risks of anti-puberty and hormone treatment for those under 18 currently outweigh the possible benefits. The UK conducted a review and called the evidence very low. They've also placed severe restrictions on the care that Dr. McNamara calls life-saving. Norway also analyzed the data and has made similar changes in policy. The National Academy of Medicine in France warned, quote, great medical caution must be taken in children and adolescents given the vulnerability of this population and the many undesirable, even serious complications the therapies cause. Doctors in New Zealand and Australia have published similar statements. Is Dr. McNamara suggesting that all these countries are rejecting evidence-based treatment and placing their kids at risk of suicide? Regarding that point of view, Finland's gender expert, Dr. Rita Kaltiela, said, quote, "It's purposeful disinformation, the spreading of which is irresponsible." All 7 countries, and Florida too, of course, concluded that kids don't need their development interrupted, the girls don't need their periods stopped and their voices lowered, and the boys don't need to grow breasts. What they need is psychotherapy. I have other objections to Dr. McNamara's testimony. She insists that her position, only hers, represents standard medical care. What she doesn't want you to know is that there is no standard. There's a debate. There's a fierce debate. And on the side opposite her stand such prominent figures as Stephen Levine, Kenneth Zucker, Paul McHugh, and James Cantor, among others. These doctors are giants in the field. They have been treating transgender patients and gathering data and publishing papers about them, and I mean no disrespect here, but since before Dr. McNamara was born. The point is that those veteran clinicians and others who have wisdom and experience are ignored because they disagree with the current narrative. They're against medical interventions for the same reason those 7 countries are. There is no evidence of long-term benefit, but there is evidence of harm. I'll end by quoting Jamie Reed, the courageous whistleblower from the Children's Gender Clinic in St. Louis. I believe that that hospital receives the medical education funding that we're discussing today. She said that doctors at that clinic said, "We are building the plane while we are flying it." We are building the plane while we are flying it. That's how they described the treatment at their gender clinic. Our precious tax dollars should not support such a perilous experiment. Thank you.
Thank you. Thank you for your testimony. The chair now recognizes Mr. Menahan for 5 minutes for your opening statement.
Good morning, Chairman Guthrie, Ranking Member Eshoo, and members of the Subcommittee on Health. My name is George Manahan, and I am testifying today as a patient and advocate in support of H.R. 2365, or better known as the National Plan to End Parkinson's Act. I'm not a policy expert like most of these people up here. I am a small business owner from West Virginia, just trying to navigate the world of Parkinson's while providing jobs to 12 full-time employees. Mr. Chairman, can I ask for a show of hands? I'm interested to know how many people on the committee know someone personally with Parkinson's disease. Wow. I asked that question because when I was diagnosed 13 years ago, at age 49, I didn't know anyone with Parkinson's. It's great to see there's a recognition of the disease by this committee. For those of you who don't know someone with Parkinson's disease, I humbly say you do now. Everyone's Parkinson's journey is different. Mine started with tightening of muscles in my right arm and leg, followed with tremors. The tremors became so bad that I would hide my shaking arm in a pocket, the couch cushions, or anything that would keep my disease from becoming public and to relieve the pain that I experienced. I was persuaded to try brain surgery known as deep brain stimulation. The results were incredible. My tremors were mostly gone, as you can see. I remember crying with my wife, Susan, in a doctor's parking lot after my Parkinson's specialist turned on my transmitter and watched my tremors fade away. But DBS is not a cure. It's an effective therapy for someone with movement issues. Over the years, my brain has slowed significantly, making it difficult for me to manage more than one task at a time. I'm sorry. They call it executive function, but I call it forced retirement. Some nights I act out on my dreams, another byproduct of my Parkinson's, and I feel I will someday injure my wife or myself. My speech has been impacted, and I am having some difficulty swallowing. One of the leading causes of death is choking on food. One of these symptoms by themselves wouldn't be a problem, but Parkinson's has a way of piling on. When I was diagnosed, I craved to find other people who had this disease, like me. But in my hometown, they were nowhere to be found. I found out later that they were home, suffering alone. So we started a 5K walk and run that blossomed into support groups and free exercise classes and caregiver forums and more. Soon we had over 200 people or more showing up to raise money, advocate, and learn from each other. A 2022 report, The Economic Burden on Parkinson's, calculates the cost of PD at $52 billion. Half of that money is paid by the federal government for Medicare. The other half is paid by patients and families. I don't believe that those figures calculate the tremendous loss of income and jobs that families experience when someone has to stay home to care for their loved ones. I often worry what will be the burden just ahead for my wife. I'm here today to speak in support of H.R. 2365, which is an important first step to relieve the economic and emotional burden of Parkinson's disease. The national plan is bipartisan, no-cost legislation that is being championed by Representative Bilirakis, thank you, and Representative Tonko here in the House, and my senator, Shelley Moore Capito, in the Senate. It's patterned after highly successful legislation that passed 10 years ago for Alzheimer's disease. What I particularly like about this bill is that patients, caregivers, healthcare providers, people who are on the front line of the disease will have a seat at the table. The legislation will bring together the public and private sector to develop a national plan. The title of the bill may seem a little ambitious. You might ask, is it possible to end Parkinson's disease? I believe it is. Through research, all things are possible. We now have a biomarker that can detect Parkinson's disease with a high degree of accuracy. Imagine we will soon be able to detect Parkinson's disease long before we see the first symptoms. This will open up research and treatment opportunities that haven't previously been available. Mr. Chairman, Parkinson's patients throughout the country support H.R. 2365. Let's take this first step together to cure the disease. Thank you, sir.
Thank you. Thank you for your testimony. Mr. O'Connor, you're now recognized for 5 minutes for opening statement.
Good morning, full committee Chair Rogers, Chairman Guthrie, Ranking Member Eshoo, distinguished members of the committee. I'm Kevin O'Connor, and it's my honor to be here representing the International Association of Firefighters, our 336,000 members who right now are on duty in each of the nation's 435 congressional districts. My written testimony has been provided. Beyond the IAFF, all major fire service organizations, the volunteers, the chiefs, the Congressional Fire Service Institute, all support the reauthorization of the Firefighter Cancer Registry. The reason is because occupational cancer is the #1 killer of firefighters. Mr. Chairman, close to your district, a 46-year-old battalion chief, Johnny Jacobs in Georgetown, lost a battle with lung cancer. He was a non-smoker and actually chaired the department's wellness program. Georgetown has since instituted a screening program, but it was too late for Chief Jacobs. Ranking Member Eshoo, 41-year-old Captain Jose Martinez from San Jose, just passed from a rare soft tissue cancer. Members of the committee, please talk to your firefighters. You will hear stories and anecdotes like this no matter where you're from. Before I traded in my bunker gear for a suit, I worked in the busiest ladder company in Baltimore County and saw my fair fires and hazmats and other incidents. As my career progressed, I delved into the actual statistics on firefighter mortality and the causes of line-of-duty deaths. I've seen friends die from cancer. As a local president, I consoled families and visited members in hospice. Then at age 52, I got that dreaded call that I had cancer. Thankfully, I beat it and am cancer-free. Firefighter is a filthy and dangerous job in which members are consistently exposed to toxins and other carcinogens. There are persistent inhalation risks even while wearing breathing apparatus. On a wildfire, the exposure to our members is non-ending, lasting through the entire deployment of their tours. Last week, as you may have seen, there was a large truck fire and bridge collapse along I-95 in Philadelphia. Those responders to that incident were exposed for many hours to billowing petroleum-based smoke, along with the dust particulates from the collapse. This happens daily. Plastics, adhesives, baked-in flame retardants, and other chemicals make today's smoke composition more accurate and deadly. Firefighters are also exposed to diesel exhaust in the stations where they live 56 hours a week. They sleep directly next to or above a garage. When an engine responds to a call, they pull out, leaving a diesel cloud trapped in the engine bay. In many stations, the Bay Area actually doubles as a rec room or training center. To add a little perspective, in 2020, the last year's statistics are available, 36 million 9/11 responses were recorded, and that doesn't include fire apparatus routinely leaving the station for inspections, repairs, trainings, etc. That's a lot of exposure. We recently uncovered data showing that our bunker or turnout gear is laden with cancer-causing PFAS that absorbs through a firefighter's skin. Simply put, our own gear is killing us. That's unacceptable. Every firefighter needs at least one and preferably two sets of PFAS-free gear for our own health and safety. We get cancer earlier and die on average at rates 15% greater than the general population, and more than 150% above average for really lethal cancers like pancreatic, lung, kidney, testicular, breast, and cervical. Those are the reasons why the World Health Organization recently named firefighting as a Group 1 carcinogen. That is their most deadly level. It is real, it is scientifically proved. Firefighting is a cause of cancer. The fire service does our best to police ourselves. We're supporting early screening processes like Gale's gallery tests that can detect over 50 cancers through a simple blood draw, or the more traditional imaging scans. Early screening saves lives. And I'd like to do a commercial for the Multi-Cancer Early Detection Act. It's very important that this is passed so these testing methodologies can be incorporated into Medicare and insurance programs. They save lives. Here's the bottom line. Without medical data, researchers and epidemiologists can't uncover trends and specific profiles to solve this epidemic. We need to track cancers in the fire service, and the Firefighter Cancer Registry is our best and perhaps the only chance to do so. It took a few years to really get the registry operational. It finally kicked off in April. Currently, there are about 4,000 registrants. Every single fire service organization is working with CDC to educate and register our members. If the registry is not authorized, we're back at square one. That can't happen. Stand with firefighters and pass H.R. 3821. I will conclude with this. From the time the registry was enacted until the end of last year, the IAFF had 959 line-of-duty deaths. 630 of those deaths, or over two-thirds, were attributable to occupational cancer. No more needs to be said. I thank you for the opportunity and am delighted to answer any questions.
Thank you for your testimony. We're now going to move into members' questions, and we're going to try to stick to the 5 minutes, so please don't ask a question with 2 seconds left in someone's time, because we won't give people a chance to answer the question of the important subjects for us today. So I will recognize myself for 5 minutes and begin asking questions. And to Dr. Thompson, I want to ask you questions. I have a good friend whose son is living with sickle cell. What's amazing what happens for members of the committee, we have people that come, we had some arguments on Pharma yesterday, Pharma. People think it's 4 or 5 big drug companies. It's actually a lot of innovative people out there trying to, small companies, a lot of them in my good friend to my left's district, who are trying to solve big problems. And I remember Dr. Francis Collins says, we can actually come into the forefront, we're going to cure sickle cell. And it's not just a chemical pill that people are going to be able to take. These are procedures, processes, genetics. They are individual medicine, and they're expensive. And so the ranking member and I have worked together on value-based agreements within the Medicaid program, so the people the most unfortunate will have access to these cares. Would you talk about value-based agreements and why it's important to have? This is where state Medicaid directors can negotiate with drug companies. Can you imagine having a state government person negotiate with a drug company and not get? I still can't believe we don't have 435 votes in the House for this. But would you would talk about why those are important to have access?
Certainly, and thank you for bringing this to attention to the committee. Yes, I think that thinking about outcome-based payment arrangements, which are currently allowed in Medicaid, can and should be extended to some of these new treatment options. The results from the early results with things, for instance, like gene therapy, are really incredibly exciting. And in the last 3 years, we have seen three new drugs approved for sickle cell disease, and we believe that there are more in the pipeline based on current clinical trials. This is something that I think could be taken on through the CMMI, the Centers for Medicare and Medicaid Innovations, looking at improving access. And I do think that looking at outcomes-based in terms of whether or not people have fewer sickle cell complications, evidence that their sickling is now gone, other parameters that demonstrate durable success with some of these treatments.
Yeah, I'd like to ask you another question. If I could move in just a little bit. Chair Eshoo and I, working together again, sent a letter to the Centers for Biological Evaluation and Research, or CBER at FDA. They responded about their meetings. They only responses for type B meetings almost 80% of the time. These are critical meetings between the FDA and regulators and product sponsors as manufacturers work through the approval process. FDA responded that 79% of these meetings for complex cell and gene therapy are without in-person meetings. Would you comment on the complexity of developing these products and what's important that we have, the challenges of developing these and not having in-person meetings with FDA?
I can't with any tremendous detail. I certainly would point out, though, that it's remarkable how much we've accomplished in part because of the requirements during the pandemic, that we have continued to have conversations. I'm at an institution where we are also among those who are developing some of these therapies, and being able to have open communications with them, whether they're in person or otherwise, today seems to be reasonably effective, and much of it has been gained by our hybrid meetings that have come out of the pandemic.
Okay, thank you. Thank you for that. So, Dr. Giroux, I have a cousin who's a neonatologist, and every time we're together, I'm not a healthcare person by trade, so I have to pick his brain. And what's amazing is the development over the last decade in neonatology and how young these babies can live. The age of viability, if that's what people want to discuss, is actually pushing back further. It's certainly not at 39 or 40 weeks. It's at, it's amazing what's moving forward. And so would you talk about what extent the PREEMIE program has contributed to these outcomes? And what's important for this hearing is gaps that you see and what we need to do better as we reauthorize the PREEMIE program?
Thank you for your question. Discovery research is vital to expanding the quality and volume of data that's needed to address the continuing knowledge gap. There is no silver bullet in treatment. Preterm birth is complex. 50% of it has no etiology. There's others that we have induced or had C-sections for babies to be delivered because of maternal health conditions. And then of course, there is that leakage of fluid and amniotic fluid, and that also contributes. The financial costs of preterm birth to society, including long-term costs and to society, is one of the gaps that families in the NICUs and post-discharge also this would hopefully help us. We would also look into social factors that preterm birth rates need to be addressed. I would also say that identifying gaps in state and federal public health programs that have caused increases in preterm birth, as well as practices that have led positive impacts.
Well, thank you. And I have only 4 seconds left. To live to what I just said, I'm going to yield back, and I will recognize the ranking member for 5 minutes for questions.
Thank you, Mr. Chairman. Thank you to all of the witnesses. Let me start with Dr. Giroux. Thank you, excuse me, for your leadership. As I was listening to you, I thought, is it really 18 years ago that we wrote this legislation? I'm very proud of it and everyone that was a part of it. Of course, we've reauthorized more than once. Briefly, because I have more than one question to ask of witnesses, what do you think has been effective over the last 15 years, and what do you think some of the causes of the recent surge are, and how does this reauthorization address those concerns?
So there are several factors that contribute to the high rate of preterm birth inadequate prenatal care and pre-existing maternal health conditions and like diabetes, hypertension, obesity, all contribute. I would say that addressing this in the future is that we are looking at exciting, promising research. March of Dimes contributes to that research. And we have prematurity research centers where actually, if you think about it, we had advancements in diagnostic tests we never had before, such as preeclampsia, which is the #1 morbidity for Black women in this country. And those are type of the solutions that we're trying to research, that this PREEMIE Act will help further.
Wonderful. Okay. To Dr. McNamara. You just sat through testimony that I believe is chock full of dangerous misinformation and pseudo-scientific, quote, facts warped to fit, I think, a really outdated narrative of the trans experience in our healthcare system. We could spend a long time talking about that, but I want to give you the opportunity for a minute to respond. I've spoken to pediatric endocrinologists in my district who treat hormone disorders in children every day. And as we all go about doing whatever we're doing, this is taking place. This is taking place in our country. And it includes, which I was not aware of, early cases of early puberty in children as young as 2 years old. I'd never heard of that. This causes, obviously, a lot of serious issues. One of the treatments is providing GnRH, analog therapy, a banned medical intervention under the legislation that's being considered here today. And I again, to have, 2-year-olds, 6-year-olds, youngsters subjected to this is, well, I think you can hear it in my voice. I'm deeply unsettled about this. Do you want to, 30-second response? Since I
Thank you,
ate up
Dr.
some of your
Silverman.
time?
Yes. So all 5 themes of the misinformation that I've identified in my work are on display. I'm a co-author of extensive rebuttals with science to all of them. It's entered into my testimony, and those documents have been used to successfully challenge bans on care for trans youth in Texas, Florida, and Alabama. The other testimony espouses 2 levels of harm: abolishing evidence-based care and creating a vacuum. The forced withdrawal of care is akin to experimentation. Dangerous, discredited conversion practices that attempt to convince a young person that they are not gay or not trans. We've moved on from that. Most states have banned that care in this country. It is toxic for an adult to tell an adolescent that there's something wrong with them. I'm sure there are many parents in the room, and you'd never want your kid to go through that. Suicidality is a debilitating way to endure adolescence. A suicide attempt is a traumatic interruption in a young person's life. Let's be clear. Pediatricians know that life-saving means life-sustaining. When trans youth receive the standard of care, they thrive. They develop talents, they discover their strengths, and they get to be who they deserve to be.
Thank you. Kevin, I wanted to know why CDC took almost 5 years to implement the legislation, and now we're reauthorizing it. But I think you're going to have to maybe answer that question for someone else, but at least to get it on the record. Thanks
Okay.
for being here.
Yeah, we'll have the
Thank you
chance
to
where we
you.
can do it
I
in
yield
writing
back,
moving
Mr.
forward.
Chairman.
Thank you for yielding back. The chair now recognizes the chair of the full committee for 5 minutes for questions.
Just to clarify, the bill does not ban treatment for precocious puberty, which the ranking member just alluded to. So a recent report found that the number of clinics in the United States focused on providing puberty blockers, hormone therapies, and surgeries for gender-affirming care has grown from just a few to more than 100 as of February 2023. Dr. Grossman, in your written testimony, you mentioned how certain European countries have decided to take a more cautious approach and significantly limit the use of puberty blockers and hormone therapies to treat gender-related conditions in minors. Is the United States an outlier?
Well, it's certainly, yes, more and more becoming so. I just want to take one moment, because this is really bothering me. Representative Eshu, I'm sorry if I'm mispronouncing
That's
your
right.
name. Representative, you are very confused about something. When we, when,
I'm sorry, we'll just suspend.
yes, Representative, I'd like to clarify something for you.
You can clarify it to me. Clarify it to me.
Yes, precocious puberty is a medical condition. It's a condition in which the child
What's that?
has abnormal.
I'm sorry, would you,
You're
could you
supposed to
spin
me
the clock this
directly,
second?
Mr. Chairman. You can't characterize me.
Okay, you can't characterize with the way that her
okay,
question, what she's asked. So if you just respond to
Okay, I'm
to the
sorry.
chair who's
Yes.
asking the question.
The point is that precocious puberty, which we've treated with blockers for decades, and is approved by the FDA for that use, that is a medical disorder. That is a disorder in which the child has abnormal hormone levels circulating that causes their bodies to prematurely enter puberty. We do not want that to happen. We're talking about an experimental use of these agents in children that are completely healthy. They have no medical disorder. So we are artificially blocking a biological process, a natural process called puberty. Puberty is not a disorder. We need to go through puberty in order to reach adulthood. Every system of the body, the brain included, needs to go through puberty to reach adulthood. And what we are doing in gender-affirming care is stopping that natural, organic process and blocking it, and then shortly thereafter, in most cases, over 90% of cases, administering the hormones of the opposite sex so that the child will go through a synthetic puberty, not the organic puberty.
Thank
But
you.
a synthetic puberty. Okay,
Thank you.
I'm sorry. You asked me about the European countries.
I asked you if the United States was an outlier.
Absolutely. The United
Okay.
States and
Thank
Canada
you.
are out.
And would you speak to what the data tells us about the long-term impacts of these medical interventions?
So that's the thing. You see, this, until recently, was an extremely rare condition. It was so rare that when I went to medical school decades ago, I never expected to see one case in my life. That's how rare it was. And now that's all I do. So you see, in the past 10 years or so, specifically since maybe 2015, there's been an explosion of cases, an absolute tsunami of cases. And the question is, why is that? And those cases are very different than previous cases. This is a new population. The prior gender dysphoric cases that we studied were mostly
you.
boys.
Okay, yes, thank you. I wanted to get to girls too, because I mentioned my concern about the mental health crisis for young girls. And over your career, would you speak to how patients experiencing gender dysphoria changed in the number and characteristics, and also speak to the long-term impacts for these medical
Okay, so what I wanted to say is that when we speak about long-term, we don't have the data yet, because this is a new population called ROGD, Rapid Onset Gender Dysphoria. And we are just studying them now. It's a new demographic, mostly girls, but lots of boys as well. My practice is 50% boys. These are kids who have a lot of previous mental health conditions.
Thank you, Dr. Grossman. Thank you. I'm going to have to cut it off there, because I heard my colleagues say that this should be a private decision between parents, teachers, and parents, children, and doctors, that we should protect parent rights, and that Republicans are putting politics between children, parents, and the doctor. The truth is, parents are being removed from their children's doctor's offices, and kids are being taken from their parents and their homes. It's making it us versus them. That is my fundamental concern. I yield back.
Thank you. The chair yields back. The chair now recognizes the ranking member of the full committee, Mr. Pallone, for 5 minutes for questions.
Thank you, Mr. Chairman. I have to say, I'm deeply disappointed in the partisan Children's Hospital GME legislation being considered today. It prescribes in very minute detail the types of care that must be prohibited in order to receive funding and tells our healthcare providers, major medical associations, and patients that Republican members of Congress know better than them about what should be considered standards of care within our medical system. And that should scare us all, particularly when this program is designed to train the next generation of pediatricians and pediatric subspecialists. So my questions are of Dr. McNamara. I know that transgender people and those who advocate for the rights of transgender people are currently facing fear, intimidation, threats of violence, but I believe that we must speak out on their behalf and support them, and I want to say thank you to you today for doing so. Now, turning to my questions, if this bill were to become law, what would the impact be on pediatric care?
So I'm very privileged to sit next to two people who have shared details about the types of medical care that benefit patients who I've cared for in my career, people with sickle cell disease, premature babies. Many people here might not know what goes into that type of care, but I do. And it's not my specialty anymore. I have subspecialty training in adolescent medicine. But the experiences that I had in a NICU in the middle of the night, resuscitating preterm infants, counseling their parents, working with my colleagues, offering advanced treatments for sickle cell to children with crippling pain, have forever shaped my training. I am an excellent clinical researcher because of my training as well. And I think that I am not the only person. You know, I spoke to so many of my colleagues about this testimony. Everyone expressed disbelief and regret that it would escalate this far. Everybody wants children to be healthy and safe, but their care and what they require to be healthy and safe is expert. We know what we're doing. We know how to do it really well. And all that we ask is that we be allowed to do it without any sort of legal interference.
I appreciate that. I mean, what I'm seeing here and in so many different forums is Republicans and Republican congresspeople trying to or determined to substitute their opinion for experts in medical fields, experts in agencies, and it's truly scary. The legislation is not only an attack on transgender youth and their families, but it's an attack on providers and the training they receive. Can you speak to how this would impact the training that pediatric residents receive? Briefly, because I have one more question.
Yes, of course. We're already seeing that less people are looking to go into pediatrics because it's been politicized and interfered with. There's a great deal of moral injury that accompanies being told what you can and can't do and needing to legally withhold care from people who need it, whose lives depend on it. So I would expect not only would it cut off at the knees the vast majority of training for pediatrics residents and fellows in this country, but it would deter the future of pediatricians.
So what you seem to suggest that this would have an impact on the pediatric workforce. You want to comment on that?
It would have a devastating impact on the pediatric workforce. People would bring sick kids into children's hospitals, and there wouldn't be anyone there to take care of them.
Well, thank you. You know, Mr. Chairman, I can't understand why the majority has chosen to hijack this critical program to have an ideological battle. I just don't understand it. This committee has a long history of working together to solve important healthcare challenges and training our healthcare workforce being one of the most important. It's just disappointing that instead of considering Representative Schreier's bill to reauthorize this program on a bipartisan basis, as we've done in the past, the Republican majority has instead decided to jeopardize the reauthorization of the CHGME through this harmful and inhumane policy. And I just don't understand it. I urge my colleagues to strongly oppose this bill, and I yield back, Mr. Chairman.
Thank you. The ranking member yields back. The chair now recognizes Dr. Burgess for 5 minutes for questions.
Thank you, Mr. Chairman. Dr. Thompson, I've worked with Representative Davis for a number of years on this issue that you've brought to us today and the reauthorization of the sickle cell disease bill. 2018 was the first reauthorization that had happened since 2004 when it was tacked on to a tax bill, believe it or not. So can you speak to why it is important that we reauthorize the bill?
And thank you so much for your long-term support. One of the important things that happened in this most recent cycle was the ability to expand this program so that it now covers all 50 states. That all of the efforts prior to that were focused on certain areas, and in fact, prior to this most recent cycle, there was a substantial region, and that is the U.S. Southeast, that was not included in competitive, as a competitive region, clearly an area where there is a high concentration of sickle cell patients. This current structure allows us not only to ensure that with this regional hub and spoke approach, that we have access in all 50 states, but they're actually now diffusing the expertise that occurs primarily at academic medical centers and ensuring that patients actually have access to physicians who are more knowledgeable, even if they are in primary care practices, even if they're in community practices. And that was a fundamental change. Sure. So the comprehensive care is dispersed, I believe, in a more equitable way.
And something you said during your testimony, there have been various FDA-approved therapies that have happened in the past couple of years. Is that not correct?
That's absolutely correct, yes.
When we sat in this same hearing in 2016, the sickle cell disease advocate was at the table where you are. I can't say that I was paying complete attention, but she made the statement, it's been 40 years since there was an FDA-approved treatment for sickle cell. And it really, I mean, it jarred me, because 40 years took me back. I was an intern at Parkland Hospital taking care of sickle cell patients in the emergency room. So in that 40-year time span, we hadn't helped. I know the things that Representative Guthrie is talking about and his value-based care that he offered in a different bill that we heard in a markup. And it is expensive, and we have to pay attention to that. But is there any way to estimate what was the cost of doing nothing for 40 years?
Oh, I forgot to do this.
I think that's a very difficult equation. You're absolutely right. But having said that, even in that 40 years when we just had one drug, that drug was hydroxyurea, a repurposed chemotherapeutic agent. And I dare say that since it was originally approved in the late 1990s, we really have seen any repeated clinical trials, many of which are federally funded, that continue to demonstrate its effectiveness, and it is not expensive. Having said that, it is currently one of the many drugs that we currently are experiencing in shortages in this country.
I see.
And so certainly we have multiple problems. We have a limited number of drugs, and then even some drugs that clearly will work. We currently are experiencing a shortage. We also still have providers who are unaware that there are any treatments available for sickle cell disease. And so we think that there are opportunities to utilize things like the Heritable program to disseminate that kind of education and training.
It's absolutely critical. Dr. Sherrill, let me just ask you a couple of questions on both the PREEMIE Act and the Preventing Mental Deaths Act. On the Preventing Maternal Deaths Reauthorization, you kind of answered this question for Representative Eshoo, but can you just speak to the fact that it is important to reauthorize to build on the work that has happened before?
Absolutely. Yeah, first and foremost, thank you. And thank you for your story of your daughter. The PREEMIE Act helps shrink our knowledge gap, I should say, and closes that gap around the data that we need to continue to fill in, to be able to do that research. We need the CDC's PRAMS program is one such highly effective tool that's allowed us to better understand trends, risks, and other factors impacting pregnant and lactating people. And that alone is in this.
So, and this will help providers, right? Taking care of those very premature infants?
Absolutely. We talked about neonatal intensive care unit who are at the bedside, who need better data. I think about the 30 years I've been delivering babies. The surfactant was a huge impact, helping lung expansion. Getting more research and solutions to help preemies is where the aim of this.
Very good. Thank you, Mr. Chairman. I'll yield back.
The gentleman yields back. The chair recognizes Mr. Sarbanes for 5 minutes for questions.
Thanks very much, Mr. Chairman. As this hearing makes clear, Congress must authorize this year several healthcare programs to continue critical data collection, research, treatment efforts that promote better access to care and cures for millions of Americans. One of those, as we've heard, is the National Firefighter Cancer Registry, which seeks to improve data collection to better target efforts to address cancer prevalence among firefighters. It's a vitally important effort because these selfless first responders are often exposed to PFAS, as we heard, and other toxins daily as they protect our communities. Mr. O'Connor, first, thanks for your lifetime of service. Thanks for your service to the citizens of Baltimore County, which I'm very familiar with. Given the high-risk exposures that firefighters face, explain again the importance of the registry, and then in particular the actions the fire service and local governments are taking to ensure that their firefighters are getting the requisite screenings, if you would.
Thank you, Congressman. The fire service traditionally has not been awash in good data. In fact, quite frankly, the data that we have is terrible. That's partially responsible for the fact that it's a local function of government. So there's never been a repository for anything really in the fire service. And as medical science and research has proven the occupational risk of cancer, we've never been able to get a handle on the overall number of firefighters who have cancer, where they're located, what specific exposures are the cause, the frequencies of the cancers, many of which are very, very anomalous. They're not the normal prostate. They're very strange cancers. What proves that more than anything else is the aftermath of 9/11. We lost 343 firefighters that day during the collapse, but since then, there's been over 1,100 who've died from various respiratory and cancer illnesses. And they're just very strange illnesses. So we're trying to get a handle on that. So the registry, when it was originally conceived, it's voluntary. But to try to actually get a full accounting of all the firefighters, career and volunteer, we encourage people to register whether or not they've been afflicted with cancer so that we develop a baseline for future studies. In our view, the best mechanism to try to deal with this is through early screening. And regrettably, there's no mechanism to do that. In our state of Maryland, the professional firefighters of Maryland, the local that you represent in Anne Arundel County, Howard County, Annapolis, the airport, their members self-pay essentially to have screenings, cancer screenings. His jurisdictions don't provide it. That's a real problem because we know that if we get firefighters early, they're detecting stage 1 pancreatic cancers, for example. That's treatable. When it gets beyond that, it's a death sentence. So our two challenges are, one, making sure that we have adequate data and making sure that our members have access to that type of testing. What would be ideal, quite honestly, if HHS followed this World Health Organization and essentially recognized firefighting as a high-risk profession so that insurance coverages would take care of these testings and our people wouldn't have to self-pay.
Thank you very much. I appreciate it. Let me switch gears quickly. One of the benefits of this graduate medical education program that we've been talking about with Children's Hospital is that it contends with two significant and intersecting challenges, one being the children's mental health crisis and the other being healthcare workforce shortages at every level of care. And this program holds a unique opportunity to help us address both simultaneously. Dr. McNamara is a pediatrician, medical professor. Can you speak to the importance of a strong GME program for children's hospitals on our ability to strengthen and expand the pipeline of both mental and physical health providers we need both now and into the future?
Thank you very much. Sorry about that. We are very good at what we do in supporting young people in navigating this new mental health crisis. We cannot do with less resources. It's simply not tenable. We do need more, but we are training ourselves in how to provide excellent mental health care by consulting with other experts. The guidelines are improving in order to kind of address the crisis that you alluded to. If we are less supported, there will be nothing that we can do. And I just have to make that abundantly clear. We cannot make do with less.
I appreciate that very much, and it's unfortunate that there's this effort to undermine the program when it can protect the health and wellness of every single child and adolescent. That concern, that focus is too important for partisan politics, so I urge the committee to take that responsibility seriously. let's pass a clean reauthorization bill. And I yield back.
Gentleman yields back. I now recognize Mr. Latta for his 5 minutes.
Thank you, Mr. Chairman, and thanks to our witnesses for being here today. And Mr. O'Connor, if I could start my questions with you. First, thanks for your service out there. When in fact, last night about 9 o'clock, right across from this building, there was a ladder truck, a pumper truck, and an ambulance right here on campus. And so we all know that our firefighters and our first responders are there 24/7 for us, and so we thank you for it. One of the things I'd like to maybe talk to you a little bit about, because I know you're talking about the registry and the baseline, the screening, you talked a little bit earlier, because again, when I look at my district, the vast majority is volunteer. And so, when you're talking about volunteers, first of all, I go to so many fish fries, pancake days, barbecues, to try to help support. But there's no way we can keep up with it for them, because again, in talking with our chiefs out there and other firemen and firefighters, you're looking at probably $11,000 to $13,000 to equip a person, just, a firefighter out there right now. And so it's pretty expensive. But, when you're talking about with the registry and the baseline and the screening, how do we work with our volunteers out there? Because first of all, with 70% of the country at volunteers, and we've seen volunteers, unfortunately, we're losing folks that they just aren't volunteering like they used to. How do we help there?
Well, first, thank you for recognizing the difference between a ladder truck and a pumper. A lot of people don't make that distinction. I don't presume to speak for the National Volunteer Fire Council, but I'll say this. Under the leadership of our new General President, Ed Kelly, for the very first time in history, our organization sat down with the leadership of the NVFC, and we're trying to forge a path together to help volunteers with retention and recruitment, and making sure that for a lot of our members, the mandatory overtimes and the staffing shortages are abated. So I share your overall concern with the volunteer fire service. They provide an invaluable service to the community which they serve, and the dedication of providers is really unmatched. With respect to the actual cancer registry and how we address that, it is more of a challenge. What we're trying to do on the career side, and departments large and small, and there's a misconception too with the IAFF, most of our locals are under 30 members. Yes, we represent New York and the big locals, but throughout Ohio, we have 285 affiliates in a lot of small towns. So we face the same challenges, but of course on a volunteer basis, they're not employees. So we're trying to figure out a way to create incentives that the people register, because their risks are no less than the risks that our people face. So in terms of your larger question, it really needs to be an overall effort. I also want to credit the U.S. Fire Administrator, Dr. Lori Moore. We had a summit, first summit in like 50 years of all the fire service organizations up in Emmitsburg, and we came out with one theme, and it's One Voice Fire Service. And I can assure you the partnership between the organizations and the providers at the local level is very strong.
Oh, thank you. Mr. Manhan, if I could switch real quick to talk to you about your very your testimony is so powerful. Hopefully we will have a cure in the future. But some of the statistics out there, in your testimony, that 1.2 million people in the United States struggle with Parkinson's today, and it's expected to double by 2040.
Yes.
I know I only have about a minute left, but could you maybe go into that? Why are we going to see a doubling of the numbers in Parkinson? What can we do?
Well, I think there are several factors. Let me give all the statistics first and then real quick, and then I'll address your question. There's over 1 million people with Parkinson's. 90,000 new people get diagnosed every year, and that's 50% higher than they first originally thought. Well, we're getting a lot of firefighters who are also getting Parkinson's disease. It's the fastest growing neurological disease in the country. The number of people with Parkinson's, as you had mentioned, is supposed to double by 2040. Chemicals are playing a role in that. I think chemicals in firefighting, obviously, but there's a lot of chemicals that people have been exposed to early on in their years, and as they grow older, they get Parkinson's disease. They make themselves more susceptible to Parkinson's disease. But I think without a congressional mandate, we may be waiting for a cure for many years down the road. I think we have the time right now to do something really, really great for people with Parkinson's.
Well, thank you. Mr. Chairman, my time's expired, and I yield back.
Gentleman yields back. I now recognize Mr. Cardenas from California for his 5 minutes.
Thank you, Chair Guthrie. Appreciate this opportunity for us to have this hearing. Really pleased to see some of the bipartisan bills that we've been working on that we'll be discussing here in this committee. But at the same time, I'm deeply disappointed in the partisan Children's Hospital GME proposal put forth by my Republican colleagues. There is bipartisanship. However, clean reauthorization that easily could have been noticed by my Republican colleagues just had to take another punch at young people, trans kids. These children, human beings just like you and me, who have done no wrong, no harm to anybody else, but just want to live their lives in truth. It's unfortunate that this bill is here before us. Welcome everybody to Pride Month. This Republican majority has gone out of its way not only to demonize access to care for trans children, but to cut off access to Children's Hospital GME resources for any provider of those services. Why? Why is it so critical that you control the medical decisions of other people's kids and of those kids' doctors? I'm once again shocked by the party of limited government stunning overreach into these private medical decisions. Now let's look at the numbers. In 2022, nearly 1 in 5 transgender kids attempted suicide. Of trans children who received gender-affirming care, there were 60% lower odds of depression and 73% lower odds of self-harm or suicide thoughts. That is, in fact, life savings. There has been real, honest, bipartisan agreement in this committee on the need to improve youth mental health, yet now we're further attacking these kids' access to care, degrading their mental health in the process, and pouring gas on the fire. You want to protect kids, all kids? Well, gender-affirming care seems to have life-saving positive impacts on the mental health of trans youth. So this isn't about protecting American kids at all. And that's what's worse. You're pulling this political stunt when we know that one of the greatest threats to our health care ecosystem is workforce shortages. It's shameful that Republicans are holding pediatric care resources hostage to score political points at the expense of already vulnerable trans children, young human beings. The price of admission to practice pediatric medicine cannot and should not be discriminated against, especially when it comes to children. Dr. McNamara, in your experience, when patients have access to gender-affirming care and can exist in gender-affirming environments, in what ways does this improve adolescent outcomes?
Thank you, Congressman Cardenas, for this question. We have spent a lot of time talking about how vulnerable transgender youth are, but I'd like to take a moment to talk about how privileged I am to be able to care for them and how privileged I am to be part of a larger medical community that does. When transgender youth have unrestricted access to an affirming social environment and to medical treatments that they qualify for and that they desire and that their parents consent to, they thrive. Now, what does it mean for an adolescent to thrive? It means that they're not their gender identity solely. It means that they develop their talents. They get really good at the piano. They learn how to ice skate. They get scholarships to college. They become productive members of our community who will make us stronger for years to come. In my clinical experience, I've seen this happen in a myriad of ways, and it's often that triangle of patient, parent, provider support that makes it happen. There's no room in there for anything else.
Thank you. We have limited time for our questioning, but I just wanted to say thank you so much for putting your heart and soul into every single one of your patients and treating every single one like a deserving human being. You say that you're privileged to have them and care for them. They are privileged to have you truly, truly care for them, to see them, to love them, and to give your heart and soul to your work and to them and their lives. Thank you very much. My time has been expired. I yield back.
Gentleman yields back. Mr. Griffiths now recognized for 5 minutes for his line of questioning.
Thank you very much, Mr. Chairman. Mr. O'Connor, can you elaborate on some of the work being done to help lower PFAS toxins in firefighter gear that would make it more resistant to both the PFAS and maybe help firefighters as well?
Technology is trying to catch up to this issue, and I'm certain that Representative Dingell will probably bring it up. I know that she and Chairman Graves from the Transportation Committee are working on a bill that will soon be introduced on that issue. The first thing that really needs to be done is more testing. It's very, very abundantly clear that this exists in a vapor barrier. The history behind it is most firefighting gear, apparatus, training, et cetera, is established by standards promulgated by the National Fire Protection Association. They have a standard, without getting into all the details, that essentially a composite a piece of turnout clothing has 3 layers: an outer layer, an inner layer that's a moisture barrier, and a layer beyond that. The moisture barrier is the area in which the PFAS is. And quite honestly, the way the standards were promulgated, only gear that had PFAS in it would be able to meet the standard. It's an ultraviolet light standard, which intuitively makes no sense because it's the middle layer of a garment. Its opportunity to see ultraviolet light is basically non-existent. And this has created the problem. So there's various enterprises studying it. The University of Notre Dame was the first one that really brought it up. I can't think of the researcher's name, but I will get you the information on some of the definitive evidence with respect to it. But there are people looking at it now, and I know there's going to be a field test that's going to begin in West Metro, Colorado. Chief Don Lombardo has partnered with his local affiliate there, and they're putting a first set of supposedly non-PFAS gear into the field. It is a major issue. I'm not the safety and health expert in our organization, but it is our #1 issue in the fire service addressing the status of our gear.
So here's one of the things I love about these hearings. And I know sometimes people think, why am I here? People are moving in and out, and we have 2 hearings going on right now, and some people have other committees. But it raises questions in your mind. So I toured a number of years ago a facility in Pembroke, Virginia, that's Giles County, a few miles outside of the area where Blacksburg is, i.e. Virginia Tech. They have a product, or they have a company out there called Nanosonic. They actually make fire gloves. So I called them. Had my team call them while I was in here listening to the testimony. They don't use PFAS. And it's basically a fabric with a glass, and I'm going to get it all wrong, but it was really interesting. It's glass inside that creates your barrier to temperatures. I mean, I've had my hand in one of their gloves over in a acetylene torch. Nothing. Now, you can only use it once, because once it's heated, the glass transforms and will no longer provide the protection. But it provides that protection while the firefighter's wearing it, and there's no PFAS. So add that to your list. Nanosonic out of Giles County, Virginia.
If I can just comment,
Yes.
I'll make sure that our safety and health people reach out to them. But as a W&L guy, I know a lot of good things come from the Shenandoah Valley. So
There you go.
Thank you very much.
There you go. Yeah, and I was W&L Law, just so you know. Yeah, that's good. Let's talk about the cancer registry itself. So you want folks to sign up for it. Is that before they have a cancer? You want everybody to sign up for it? And how does it work? And then how does it identify what the cancers are? And can it eliminate, or can it maybe focus in on some of the substances that are causing these cancers?
I alluded to in my oral testimony
Yeah.
is it really just started in April. And part of the reason to answer, I know she's no longer in the room, but the ranking member's question is it was a combination from what we've been told. We're obviously sorely disappointed that it's taken this long, but a combination of COVID and some cyber issues related to protecting people's personal health information.
Yeah.
So that's what the delay was. And again, right now we only have 4,000 people. We want everybody to sign up because the key is a baseline.
Yep.
When people are hired in the fire service, there's fitness requirements. So generally, people come in are a heck of a lot healthier than the general population. It's one of the reasons that local governments always want firefighters included in their medical plans because we bring down the risk.
Right.
As the exposures occur over the years, that's when the cancers develop. So what we need is for the kid that comes into the fire academy or the volunteer,
You want to follow him all the way
test them
through it.
immediately and follow them through the course.
I'm running out of time. I want to ask one more question. It's not because I'm against it. I'm just curious because I'm going to have to defend it with some of my friends. The number in the bill is almost double what it was previously. Can you tell me quickly why the reason for that is?
The technology, trying to trace some of it. And again, I think it's, in the scheme of things, it's a very modest.
It's 5.5 million
Right.
overall. That's after it's been doubled. All
Yes,
right, I
sir.
yield back.
Gentleman yields back. I now recognize Mrs. Dingle from Michigan for her line of questioning.
Thank you, Mr. Chairman. I want to thank all of the witnesses for being here today because you each have a very personal story, and we understand it, and it's hard, and quite frankly, I've been on the board or worked with almost all of your organizations, and members have personal stories here. So I want to just thank you for that and sharing that with us. My late husband used to say that our children are 25% of our population and 100% of our future. And I know that it's really important that we make sure that we've got all the tools and resources to make sure that all of our children live and grow and thrive, and that should be one of our top priorities. So I do have to make a point before I get to my other questions that I am concerned about the dangerous impact of the current bill we're considering on reauthorizing the Children's Hospital Graduate Medical Education Program, because I think we're putting politics into deeply personal health care decisions. The CHGME program extends far beyond transgender youth. It provides vital federal support for children's hospitals across the nation. The program trains 56% of all general pediatric residents. Its importance in training the workforce that keeps our children healthy and safe cannot be overstated. But this bill would not only prohibit funding for gender-affirming care, but it withholds funds from any hospital providing it. Just in my state, the Children's Hospital in Detroit and the University of Michigan treat anybody who comes through its doors. These are mental health issues, and we really need to understand what we're doing here, and I think it's unacceptable. But I want to turn my attention to the bill that deserves our full support. It is bipartisan, the Gabriella Miller Kids First Research Act 2.0, which will reauthorize and increase funding for pediatric care research. I was glad to introduce this life-saving bill alongside Representative Wexton, Cole, and Bill Arakis. For those who don't know, DIPG is a devastating pediatric brain tumor. It's almost always fatal, and the average overall survival for children diagnosed is less than 1 year. The bill is named after Gabrielle Miller, a childhood cancer advocate who lost her battle with DIPG when she was 10 years old. But I've had the sadness, unfortunately, of working closely with children and families struggling with the horrors of DIPG, like the Carr family. Jason's the father, Chad Carr. I lived with him from the time that he was diagnosed until he died at age 5, and Jack Demeter, a young boy who lost his battle with DIPG at the age of 3. Watching someone live with cancer at any age is hard, but it's gut-wrenching when you're watching a child. So, Dr. Thompson, I know you're here to discuss sickle cell disease, but within your capacity as Chief of the Division of Hematology at Children's Hospital of Philadelphia, you're also a professor of pediatrics. Could you talk about, or do you agree that more robust funding for pediatric cancer will help find new treatments and cures for young patients? And can you also, because I'm not going to have a lot of time and I got to get one firefighter question in, talk about why childhood cancer differs from adults?
I'll my best, but certainly there are many childhood cancers that are completely unique. They are not ones that occur at an early stage in children. Some of them actually occur only in children. We've made some remarkable advances in pediatric care, such that 80% of children, because of research, are surviving. DIPGs, children with DIPGs, unfortunately, are not in that group. We're lucky if they survive 1 year. These are the opportunities for research, and many of our children's hospitals are also some of our most important sites for pediatric research. Pediatric research only makes up about 10% of the NIH's budget, but what we do with that is remarkable. And so certainly we look for it to be funded by nonprofits, by private-public partnerships, as well as other governmental agencies. But we can't underscore the number of advances that we've made in pediatric care that have largely come from evidence bases, and those are from research.
Thank you. Okay, 20 seconds left. Mr. O'Connor, I've highlighted, and I want to thank my colleague who really asked the questions that I was going to ask, and I hope Mr. Graves has been busy, so we're hoping to get our bill back, and we hope you'll join us. But is there anything that, you've highlighted the importance of it and the danger, is there anything you want to add in 3 seconds?
Just that it needs to get done. Our lives are at stake, and we thank everybody for their leadership and support of it.
Thank you for all our firefighters do. I yield back, Mr. Chair.
Gentlelady yields back. I now recognize Mr. Bilirakis for his 5 minutes.
Thank you. Thank you, Mr. Chairman. I appreciate it very much. I want to specifically thank Chair Rogers for including 2 of my bills, the Gabriella Miller Kids Bill with Representative Dingell and a couple others, but also the National Plan to End Parkinson's Act. Thank you very much for including them in today's hearing. The Gabriella Miller Kids First Research Act 2.0, H.R. 3391, is legislation I co-lead, again, with Representative Wexton as well, and, of course, Representative Tom Cole. And it would authorize the important pediatric research initiative at the National Institutes of Health, NIH. Sadly, cancer is the single leading cause of death of children in the United States of any disease, approaching 10,000 diagnosed annually under the age of 15. We still have a long way to go to improve survival for our most vulnerable patients, our children, who are diagnosed with brain tumors, prevalent cancers, and other pediatric rare conditions. We must continue to allow this program to conduct the critical research needed to improve outcomes and accelerate treatments and cures. My other bill is H.R. 2365, the National Plan to End Parkinson's Act, that I lead with Representative Tonko. And it would unite the federal government through an advisory council of public and private stakeholders in a national effort and strategy to support research, development, recommendations with the goal of treating and curing Parkinson's disease. So I have a question for Mr. Manahan, and I'll tell you what, you did an outstanding job, sir. Thanks for sharing your story. We really appreciate it very much. It makes a big difference when you hear the personal stories. Thank you again for sharing your short story. Your advocacy is extremely impactful, and I greatly appreciate you sharing it. You have highlighted the burden that this disease has on the patient and the families, physically, emotionally, and financially. I personally understand this. My uncle died from Parkinson's, late 50s. My brother just passed away just over a month ago in Parkinson's. He was diagnosed in his mid-40s. My father has Parkinson's early stages, and my mother-in-law mid to late stages. So I understand the disease, even though I'm not a physician. So again, the lack of treatment options leave patients, families, and the American taxpayers in a terrible predicament with little place to turn, as you said. Could you please elaborate on why this legislation is so vitally important right now? Time is of the essence.
Yes, sir. I am excited about the national plan because for the first time, it's going to give the federal government and stakeholders a chance to sit down and talk face to face. There's going to be a seat at the table where it hasn't been before for patients, caregivers, Parkinson's specialists and doctors. And I think without a mandate, it's not going to happen. And we need this plan because I fear that if we don't do something this year or next year, the problem is going to be that we will not come up with a cure for Parkinson in years, which I hope, versus decades.
Thank you. And I want to also commend Michael J. Fox, obviously,
Yes.
what he's done, his foundation, what he's done to find treatments and potential cures for this disease. And I know they're behind this legislation as well. So he has been extraordinary. There's no question. I've talked extensively about the need to ensure we are coordinating federal efforts. That's the key, coordination, rather than a duplicative and siloed approach to healthcare. And initiatives like Operation Warp Speed prove that with the right public-private partnership, we can accomplish a significant amount. So again, Mr. Manahan, what will the creation of an advisory council mean for coordinated and comprehensive public and private research?
Well, I look at the biomarker, which I had mentioned earlier today, as the hope for the future. But this legislation is a hope for the people that have the disease right now. It's going to bring together the Michael J. Fox Foundation and the private foundations and the federal government. In fact, I talked to someone who served on the advisory board for Alzheimer's. Mm-hmm. And one of the things she said to me was that this national plan really worked out well because the federal agencies got a lot of opportunity to find out what they're doing. So it's just not the federal agencies and the private foundations talking, it's actually federal agencies talking amongst themselves.
Yeah, and this piece of legislation is modeled after that piece of legislation.
Yes, sir.
To cure
Sure is.
Parkinson's, Alzheimer's in this case.
Correct.
Thank you very much, and I really appreciate it. I have a couple more questions, but I'm not going to go too far over. So I appreciate it, and I yield back, Mr. Chairman.
Gentleman yields back. I now recognize Ms. Custer. Mr. Ruiz showed up. Didn't see him down there. Dr. Ruiz.
Thank you, Doc.
Recommended is
just
recognized. I'm recommending him too, but he's recognized for 5 minutes.
Before I begin, I want to give a very special recognition and shout out to students from my district from the Migrant Farm Worker Education Program that are here visiting Washington, D.C. Some of them are walking in right now. They are very, very, very special to me because my mother was a migrant farm worker who toiled the fields day in and day out with calloused hands and tired backs and minimal rest day after day after day. And they're attending the same schools that I attended, and I am true and blue from the farm worker community. And so if you don't mind, let's give them an applause for being here. Thank you. Thank you very much. I want to touch on two different topics here today. First, I would like to address the policy that would pull funding from children's teaching hospitals that provide age-appropriate, gender-affirming care for transgender and non-binary youth. I echo my colleagues who have already spoken out to protect the relationship between patients and their doctors, and this harmful and misleading rhetoric and policy that purports to protect kids is actually doing the opposite. It is a bully policy that bullies some of our most vulnerable kids. Research shows that gender-affirming care improves the short and long-term mental health and well-being of trans and non-binary youth. The science is there. The studies are there. And every major medical association supports it. Decisions to get age-appropriate, gender-affirming care is one that should be made by parents and their kids in consultation with their doctor, not by the federal government. And in addition to placing transgender and non-binary youth mental health at risk, these policies are also risking the future of our pediatric workforce. We already have a pediatric shortage. Children's hospitals train half of our country's pediatricians, and this proposed policy only forces those hospitals to choose between doing what is best for their patients or training the next generation of pediatricians. Dr. McNamara, as a doctor, and I'm very concerned how this policy will harm the mental health of our transgender and non-binary youth, as well as the future pediatric workforce of our country. Can you address the consequences these policies will have both on our transgender and non-binary youth and on our pediatric workforce?
It all goes hand in hand, sir. Thank you for your question, because it highlights the fact that pediatric healthcare is a tightly knit fabric, and you cannot pull out one thread. The whole tapestry would unravel. The healthcare of one child is, we don't think about it like that. I guess we don't parse out groups of youth and say, well, it's okay to care for you and it's not okay to care for some of them. So we simply would never accept this policy. As far as mental health goes, even just the rhetoric that we've heard today is very damaging and harmful to trans youth. I think that one of the reasons why rates of suicidal ideation over the past couple of years and other mental health harms in trans youth has been going up is because of how they've been demonized.
Yeah, and the rhetoric leads to depression, leads to anxiety, leads to suicidal ideation. It also encourages others to use the same rhetoric, their peers, that leads to bullying. Transgenders are already number one on the hate violence crime list. So I'd like to pivot to another topic, cancer detection. Mr. O'Connor, thank you for your remarks today, and for General President Ed Kelly's and the International Association of Firefighters' longstanding leadership in promoting the health and safety of our nation's firefighters. Thanks to your work with Congress to establish the Firefighter Cancer Registry, we now know that cancer is the leading cause of death for firefighters, exceeding heart attacks, smoke inhalations, burn injuries, vehicular accidents, and other fatal injuries. In fact, firefighters face a cancer risk that is 14% higher than other Americans, and it's truly an epidemic. So the IAFF's leadership goes beyond researching the data. You're leading the nation in ideas. Look, I helped lead the effort on the burn pits and the associated ingestion of the toxic smoke. So I know that a lot of the things that burn have carcinogens. Will you, Mr. O'Connor, will you share with the committee how the ability to find more cancers earlier would benefit your retirees, their families, and so many others at risks, seniors across the country?
Real quickly, before I answer that directly,
You only have 15
I know. I
seconds.
want to add that wildfires, the constant smoke, is exposing to everybody, including citizens. Screening
agree.
is the key. Screening is the key. If we get our people in early and we're able to track it, we will be able to solve we'll be able to cure the cancers and catch them at early stages. But screening is crucial.
Great. Well, I truly support this bill and I also have another bill called the Nancy Gardner Sewell Medicare Multi-Cancer Early Detection Screening Coverage Act, which will be able to more efficiently detect cancers early, and I encourage the committee to also look into that one.
I know we expired. I mentioned that in my oral testimony.
Thank you. Bye.
Gentleman yields back. Now recognize Mr. Johnson from Ohio. 5 minutes.
Well, thank you, Mr. Chairman. I want to thank Chairman Guthrie for having this hearing today, and thank you to our panelists for joining us here today. We're considering a number of bills and important reauthorizations here today, including the Children's Hospital's Graduate Medical Education Payment Program, which funds freestanding children's hospitals. This money helps their graduate medical education programs train resident physicians and dentists. We all understand the toll that the pandemic took on the most vulnerable in our society, particularly our children, from not being able to go to school, something we will not know the true side effects of for years to come, to masks and anxiety. COVID-19 weighed heavy on America's boys and girls. It's critical that we support our nation's children's hospitals. Nothing is more important to me than ensuring the mental and physical health of our young people. That's why I'm proud to support Representative Crenshaw's legislation reauthorizing the graduate medical education payment program. Yes, I am deeply troubled by reports that a growing consortium of American medical professionals are pushing highly controversial treatments like gender-affirming surgeries, hormone therapy, and puberty blockers on children and teenagers when we do not know the true impact of their long-term mental and physical health. So question number one, Dr. Grossman, in your position as a child, adolescent, and adult psychiatrist, what types of treatment methods for kids diagnosed with gender dysphoria are backed by scientific data? If you need me to repeat that, I will.
No. I heard you. Thank you very much, Congressman, for the question. We have known for decades that if these kids are left alone or just given psychotherapy and family support, that the vast majority will become comfortable with their sex, with being a boy or a girl.
Mm-hmm.
We've known that for a very long time. Recently, we've started applying so-called gender-affirming care to a new cohort, a new group of kids that we've never seen before. And those are kids who suddenly, out of the blue, develop the gender dysphoria as part of what more and more people are realizing is a social contagion.
So you're saying that if they receive the kind of support at home and mental health counseling, traditional mental health counseling, that they grow through this phase and they become comfortable with who they are.
Yeah, I'm not saying every single
Sure.
person.
Sure.
But in the past, the research that's been done on those kids would say so.
Well, that's interesting because, you know, as my colleagues across the aisle frequently like to say, we need to follow the science here. In Dr. Grossman's opening remarks, she noted that the United States is moving in the opposite direction from our European counterparts in terms of how those nations view gender dysphoria treatment. Simply look at our friends in Great Britain. Just recently, the National Health Services in London announced that publicly funded services will no longer routinely offer puberty-blocking drugs to children. This on the back of a 2023 global public opinion survey of 30 countries asking whether or not transgender teens should be allowed to receive gender-affirming care. This survey showed the United States as having even less public support for these treatments than virtually every single European country polled, including the UK. The fact of the matter is the United States is moving in the wrong direction. It's moving in a very extreme direction and is becoming a global outlier on this issue. I personally believe it is irresponsible and essentially child abuse to allow minors to make these types of life-changing medical decisions. But on the facts, we simply do not know enough to say for certain that we should be allowing these treatments at all. I find it disturbing that some children's hospitals are pushing puberty blockers or hormone therapies on children incapable of understanding the long-term effects of these treatments. Children's hospitals are meant to be the gold standard of pediatric care in our communities, and their support for such programs will lead parents and families to trust what they are saying despite the data telling a different story. I do have other questions that I'll submit for the record, Mr. Chairman. I realize my time has expired. This is a real important and emotional issue for many of us, especially those of us who are grounded in our faith and as parents. We see this as an aberration.
Gentleman's time has expired.
I yield back.
I now recognize Ms. Custer for her 5 minutes.
Thank you, Chairman Guthrie. I'm glad this committee is dedicating time to reauthorizing several important health programs, all on a bipartisan basis. The list is impressive: supporting premature infants, expanding the dental workforce, committing federal resources to end Parkinson's, protecting our firefighters, to name a few. Today's hearing should be an opportunity to celebrate the important role that Congress plays in dedicating resources to people with rare diseases and providing support to our country's health workforce. However, I am extremely disappointed as a parent that today's hearing includes a partisan attempt to villainize children and bring politics into our healthcare system. I recently had a lovely breakfast with our chair. We share a concern about the well-being of our youth. But I want to quote her comments at the beginning of this hearing. She said she wants to send a message to our children that they are loved as they are. Trying to scare our nation's pediatric hospitals into denying gender-affirming care to patients to fit a political agenda is not just cruel, it's nonsensical, and it puts the health of millions of children at risk. As Dr. Ruiz has recounted, and our experts today have affirmed, this type of rhetoric from members of Congress in hearings like this leads to suicidal ideation and bullying and is harmful to our children. Let's make one thing clear right now. The government has no role in policing what care doctors and nurses should provide to their patients. Medical decisions are between a patient, their family, their parents, their guardian, and their physicians. Trying to insert the federal government into these incredibly private, incredibly sensitive decisions is simply unacceptable. In my home state of New Hampshire, our state motto is to live free or die. We value privacy. We value the privacy of our medical decisions, and we do not need the United States Congress to interfere in that privacy. This legislation flies in the face of our state motto. So, Dr. McNamara, in your testimony you state that healthcare providers must consult with parents and legal guardians about care that's provided to children. Could you explain to this committee and to my colleagues the importance of informed consent when providing all kinds of medical care to our youth?
Absolutely. Thank you for your question, Congresswoman, and thank you for your comments. It makes my patients feel safer. Parents play a central role in all medical decision-making for minors in the vast majority of cases, and regarding medical treatments for gender dysphoria, it's no exception. Parents know their kids best. They know what they need. We as pediatricians rely on their knowledge of their young person in order to help support them best. In the case of medical treatments for gender dysphoria, the standard of care and the way that care is practiced in this country is with a multidisciplinary team with an iterative over several visits, several months mental health assessment, and long conversations that don't really have an endpoint. That may be a little bit different from other aspects of pediatric care, but it's something that my colleagues and I are very skilled at doing. We know how to do it, and this care overwhelmingly benefits transgender youth.
I just have to, as an aside, I was an adoption attorney for 25 years, and I primarily represented birth parents who made the decision to place their children for adoption. And I can remember working with 2 teenagers. I remember when we went before the judge looking over and realizing that the young man had never shaved. He still had the peach fuzz on the side of his face. And trust me, there was no room for the federal government in making those personal, private decisions about our health, our well-being, and the well-being of our families. I just want to say that the claims that we hear about gender-affirming care in this room and in the media are dangerous, and I want to join my chair in sending a message to our children that they are loved as they are. Thank you so much. I yield back.
Gentlelady yields back. I now recognize myself for 5 minutes for my line of questioning. I am a physician, and I understand the issues related to gender dysphoria. And I do recognize it's real. However, I can never support permanent surgical procedures on children, regardless of the other need for treatment for their dysphoria. Again, I would remind everyone these are irreversible. Permanent surgical procedures, in my view, should not be part of a treatment plan for transgender children. In the House Energy and Commerce Committee, look, we're a legislative workforce. You look at the House floor, a lot of our bills come from here. And we managed to do much of our work on a bipartisan basis, and we're doing, I think, mostly that today. And I'm proud of that. We're continuing to be a workhorse for Congress, as we have a number of important public health priorities we're discussing here today. So I'm going to ask a couple of questions. Is it Dr. Chereau? Dr. Chereau, in Indiana, we have the third highest maternal mortality rate in the nation, with 44 deaths per 100,000 live births as of 2022. According to the March of Dimes' own data, Indiana has an infant mortality rate of 6.6, which is higher than the U.S. rate of 5.4. These are statistics we're not proud of, but our governor and our state government, as well as the medical community, are trying to find ways to improve this, and we're focusing on that. Can you talk about how H.R. 3226 and H.R. 3838 will benefit mothers and babies in states like Indiana, and how this will help us advance?
Absolutely. Thank you for the question. Within states, we have our MMRCs and are really important to look at the details of the deaths that do happen. And what happened is that we identify those contributing factors, using that to then translate those into action. And those MMRCs are important across every state to collect that data. I would say that the federal collection activities underpin the work of the March of Dimes, and that those agencies and partners address the maternal and infant health crisis. We want to increase that data to get to solutions that are vital to be able to impact.
Well, thank you. I just want to say we've had a hearing in the past, a number of hearings in the past on this, and we had data out of Parkland Hospital in Dallas, Texas, famous hospital, and their data is outstanding on this issue, on maternal mortality, and they have defined protocols on how they manage the patients. And their patient population are primarily the underserved, uninsured, and also ethnically diverse population. So this can be done. Correct?
Yes, absolutely. We've seen states that have changed their outcomes using different PRQCs to get to really standardized protocols, realizing that there are lots of impacts that we can have both on maternal death rates as well as preterm birth.
Yeah, and it's shocking that this does cross socioeconomic class also. You may or may not know, we just had a famous athlete who we found out what resulted in her death tragically at home. And why that happened, I don't think we know. Dr. Thompson, can you talk about what innovation means to patients with sickle cell disease? That's kind of open-ended. I want you to basically comment on what you want to say about where we are in innovation and what we can do.
Thank you. And innovation actually is a spectrum. Innovation, I think in its best possible terms, really is looking at discovery, science that moves to the bedside. And so if I were to look at the best case scenario today is a possibility of gene therapy for a variety of blood disorders and immunodeficiencies. For some people, innovations is what I otherwise call standard of care, because today there still are individuals in this country whose current providers, whose current communities lack resources for them to actually understand what's available to them. So we know that there are now a number of disease-modifying therapies that have been FDA approved across a wide range of ages. If innovation means that those individuals now have access to those, then certainly that should also be a form of innovation that I hope we would also embrace.
Yeah, I'll finish with this. I did my medical school at University of Illinois in Chicago, and at Cook County Hospital, we had a lot of people come in sickle crisis, and this is just it's particularly genetic therapy. It's exciting because it's just a tragic disease. Also, people in renal failure and other organ failure because of it. So I'm excited about the future, particularly of gene therapy and diseases like sickle cell. With that, I yield back, and I recognize now Ms. Craig for her 5 minutes.
Thank you so much, Mr. Chairman. I'm incredibly disappointed to see my Republican colleagues today taking what has always been a bipartisan effort to reauthorize a program that we've always supported and twisting it into a partisan process that undermines parents' rights and ignores evidence-based care guidelines for the treatment of trans youth. We should be here today to support a clean reauthorization of the Children's Hospital Graduate Medical Education Program. But oh no, you're putting the program in jeopardy in support of your continued culture war crusade. Look, I have a news flash for my colleagues. It is none of your business what evidence-based care a parent in consultation with their health care provider decides for their child. In fact, after listening to you today, I am absolutely certain that most of you have no idea what the range of gender-affirming care actually is. So let me start with that. Dr. McNamara, can you define for us what age-appropriate, gender-affirming care actually is for my colleagues, just a little bit?
This is absolutely crucial. Thank you so much for the question. Gender dysphoria is real. It represents a discordance and distress that emerges from the difference between, I mince my words. It's the difference, and I mince my words again, I'm so sorry. It is distress that emerges from the difference between sex assigned at birth and gender identity. Without treatment, this care with this condition is dangerous and debilitating. Gender-affirming care starts with affirmation. It starts with very simple things like, is it okay to get a haircut? Is it okay to wear certain clothes or to change your name into something that feels more authentic? And from there, we see that youth begin to blossom. Some youth qualify for and desire medical aspects of gender-affirming care, and it's a highly individualized process. It depends on who the young person is, their parents, and the conversations that evolve from there. There is no endpoint, and there is no prescripted plan of care. It depends on the person who's before us.
And Dr. McNamara, that care has been supported by 20 major medical associations, including the American Academy of Pediatrics, the American Psychological Association, and the American Medical Association. Am I correct?
Absolutely.
Can you, just for a moment, rebut the claim that has been made here today that the United States is somehow an outlier in the care that gender-affirming care represents?
So I urge this body to make any decisions based on sound information and science. No other country in the world who is a peer of the United States has gone as far as to ban and criminalize the provision of medical treatments for gender dysphoria. What you have heard today is a cherry-picked collection of unverified information that portrays outlier views in some countries in this world. There are many countries in this world that nobody has brought up today that I could list off, like Ireland, Australia, Spain, Portugal, Canada, Mexico, among others. But this is the greatest country in the world, right? And our medical science and innovation here is amazing. I'm so privileged to be able to practice this care.
Dr. McNamara, thank you so much. You've already spoken to how dangerous it can be if that care is denied or if medical professionals are not appropriately trained in order to treat this and provide this care. I get that some of my colleagues think this topic is a political winner. I would extend an invitation to every single one of you, many of whom I respect, to attend a panel of parents of trans youth to hear their stories. What you are attempting today undermines the rights and responsibilities of the parents of trans kids and is opposed by all the major medical organizations in our nation. We agree, Madam Chair, I have so much respect for you, that the goal is to love our children for who they are. Some of our children are transgender. Do we have enough space in our hearts to love and accept them too for who they are? Some of your kids and grandkids will be trans. Do you really want any politician sitting in this room involved in their health care decisions? And with that, I yield back.
Gentlelady yields back. I would now recognize Ms. Harshberger for 5 minutes. Surprised her.
Yeah, you surprised me. Thank you, Mr. Chair. Thank all the witnesses for being here. And Mr. Monahan, I'm proud to be an original co-sponsor of the National Plan to End Parkinson's Act introduced by Reps. Billrockis and Tonko. The bill aims to unite the federal government in a mission to cure and prevent Parkinson's and alleviate financial and health burdens on American families and reduce government spending over time. And the biomarker, which detects the protein that's associated with damage to neurons that's used, now you can detect Parkinson's earlier, is amazing to me. My father has suffered from Parkinson's. He'll be 90 next month, and it's an ongoing battle, and I understand everything you're talking about. And the younger you are, the more problems you have as you age. The National Institutes of Health is a federal agency with the largest budget for supporting Parkinson's disease research. I think $259 million in 2022. My question is, do you have a sense of what the NIH thinks of this legislation?
Well, Dr. Richard Hodis, who is the director of NIA, testified in the Senate and answered a question from my senator, Senator Shelley Moore Capito, about whether or not they thought that the national plan would be something that they would support. And his quote is, he found it to be extraordinarily valuable. I have not had any other conversations with NIH or NIA, but apparently the NIA, Richard Hodis, supports it.
Okay.
Thank you.
Thank you. Dr. Chereau, I know the March of Dimes is a strong advocate for the PREEMIE Reauthorization Act and to reauthorize the important federal research, education, intervention programs to improve pregnancy outcomes and infant health, of course, to reduce the premature preterm births and infant mortality. And I'm pleased we're taking that legislation up. I wanted to ask you about another issue, though, that has come across my desk. It's about the aluminum content in parental nutritional products. It's been recognized for decades as a toxic contaminant, especially dangerous for preterm babies due to their immature kidney function where they can't, expel that. And it causes bone toxicity, brain toxicity, developmental delays, and premature babies are especially susceptible to aluminum toxicity because of their digestive systems that are not fully functioning. Previously, the FDA took the position that preterm infants not receive more than 4 to 5 micrograms per kilogram of body weight of that aluminum product. Now the FDA is poised to raise that aluminum to almost 17 times the previous approved standards. Does the March of Dimes agree that we should continuously strive to reduce those aluminum levels in prenatal products and that the FDA should not approve or permit to remain on the market products with high aluminum levels when lower aluminum products are available?
So first, I appreciate the question, but I'm not a nutritionist, nor am I a neonatologist. So I'm an obstetrician gynecologist.
Okay.
But I would say the March of Dimes is absolutely advocating for research in nutrition, specifically breastfeeding, as well as nutritional supplements, to look for the best things for premature birth for those babies. But I'd have to get back to you on that answer.
Yeah. I wish you would do some research on that because there's...
I'll note that, yeah.
Yeah,
absolutely.
there's a lot of toxic side effects associated with that aluminum product. So for them to change course on this is, to me, unacceptable. So thank you for that. And with that, Mr. Chairman, I yield back.
Gentlelady yields back. I now recognize Ms. Kelly for her line of questioning.
Thank you so much, Mr. Chair. I'm so happy to see so many bipartisan bills to improve the state of the healthcare system for all Americans. First, I'd like to recognize the Bipartisan Action for Dental Health Act of 2023 that I gladly led with my colleague, Rep. Mike Simpson. Oral health affects our ability to eat, speak, smile, and show emotions. Oral health also affects a person's self-esteem, school performance, and attendance at work or school.
Regular preventive dental care is essential for oral good health, so one can find problems earlier when they are easier to treat. Unfortunately, many don't get the care they need. More people are unable to afford dental care than other types of health care. Children, low-income Americans, minorities, and the elderly are especially at risk for having limited dental care and poor health outcomes. I would also like to submit for the record a letter from the American Dental Association in support of this legislation, which provides a crucial workforce grant program focused on providing access to care for those most in need. Additionally, I'm elated to see so many bipartisan bills being brought forward to address the maternal health crisis. I'd like to take this moment to pay respects to Tori Bowie, a 32-year-old black woman who was an Olympic-winning track star. Unfortunately, she passed away on May 2nd. A preliminary autopsy has determined that her cause of death is attributed to possible complications of pregnancy. And I am so tired of learning about these stories, especially when data shows that 84% of maternal deaths are preventable. This is unacceptable. I will continue to work on legislation to address this issue. I'd like to thank my colleague, Rep. Burgess, for including a piece of my mama's bill in the Preventing Maternal Death Act. And I'd lock arms with anyone who wants to make this country the safest place to give birth. Dr. Sherrod, would you please elaborate on how maternal mortality review committees determine if a pregnancy-related death is preventable? And do any state MMRCs in particular stand out as a success story so we can continue to promote best practices?
So first, thank you. Yes, MMRCs are crucial at getting at the data, and they meet their state, federal, really getting to all of the data from the stakeholders and getting to our PQRCs. Our maternal mortality rates are better in some states than others. And just as the March of Dimes puts out data on maternity care deserts and preterm birth, we also look at this data exclusively. Specifically for your state, I'm dragging data through and hoping that my crowd is pulling up yours. But there are some that are much, much better because they take the data and then really put into action some of the stuff that comes out of the American College of OBGYN and AIMS, really looking at how do we standardize protocols and procedures for some of the most crucial, like hemorrhage, like cardiovascular. And we've made huge efforts in those, and there's more to come that needs to be done. And clearly, Black and brown women are suffering in this country. And our Olympian died in the month of May. And she died what they think, we don't know, but what has been put out in the press is on eclampsia, which is seizing. I've dealt with this many a time, and it is preventable. And she was supposedly found in labor and preterm labor. So not only do these women suffer, their babies are dying too and are more likely to. So thank you for bringing that to the attention.
Well, thank you for your work. And I just wanted to tell Mr. Manahan, my grandmother had Parkinson's, and I wanted to thank Mr. O'Connor for your service. I used to work for local government, so I know how important you are. Lastly, I would just like to state that it is unacceptable that clinics and clinicians that provide gender-affirming care to our youth have seen a rise in harassment and death threats. I've heard from those who are on the front line and want to speak up, but are remaining publicly silent for the safety of themselves and those around them. This is unacceptable in our society. I'm proud to speak up and speak out on their behalf. Defunding postgraduate pediatric training programs if they give proper care to transgender youth is reckless and dangerous. The federal government should not be involved in the healthcare decisions between a parent and their child. And with that, I yield back. Thank you.
Generally yields back. I now recognize Mr. Carter for 5 minutes.
Thank you, Mr. Chairman, and thank all of you for being here. This is extremely important. As a healthcare professional, healthcare outcomes have been my focus since I've been a member of Congress, and long before that, even when I was a member of the Georgia State Legislature. I am from Georgia, and we have one of the highest maternal mortality rates in the country. And for the life of me, I cannot figure that out. It baffles me.
I do not understand why Georgia has such a high maternal mortality rate. And it's something I have worked on for probably the last, when I was in the Georgia State Legislature and when I've been here, so probably 20 years. And I think I'm just as confused now as I was when I started. And it's really disappointing. The CDC just recently released data that showed that the number of pregnancy-related deaths in the United States continued on an upward trend in 2021, with over 1,200 deaths that year. 1,200 in America, in the United States. I'm just baffled by this. But I'm proud that I'm co-leading, along with Dr. Burgess, legislation to preventing maternal Deaths Reauthorization Act, and hopefully we can get that passed, and I think we will, and it is very important. Now, I know you were just talking about maternal mortality review committees, and they are very important. In fact, when I was in the Georgia State Legislature, we passed Senate Bill 273, which created the MMRCs, putting it into the Georgia Department of Public Health, and it was one of the things that we've done to address this embarrassing situation that we have in our state. Dr. Charoux, I wanted to ask you, again, we talked about the role of MMRCs, but why are they so important?
Well, they're vital in understanding the causes and implementing changes to prevent future tragedies. Most of the information on maternal deaths cited today are based on data from MMRCs, and we need more of it.
Okay. Well, let me ask you, are you familiar with Georgia and how
Yep.
they're using it?
So,
Because that was legislation I worked on when I was in the legislature there.
yeah, because the Preventing Maternal Deaths Act grant funding to be sustained. So yes, in Georgia, they recently published a series of recommendations for providing these case management services for women during pregnancy and up to 1 year postpartum, implementing a blood pressure check at 72 hours. Not 3 weeks, not 2 weeks, but 72 hours after discharge when a patient has preeclampsia.
Good.
They educate patients, right? They also provide reproductive life planning and counseling, and they improve communication coordination for patient care.
Good. Well, thank you. And I want to shift gears real quick and talk about sickle cell disease because, again, here we are in Georgia, and we got some of the highest rates. And I'm proud of my state, and I love my state. It's my home. It's where I've lived all my life, where I intend to live the rest of my life. But I just cannot figure out why we're leading in some of these things. And sickle cell is, and as a pharmacist, I know and I've seen and witnessed just how awful a disease it is and how painful it is. But Georgia's home to one of the largest sickle cell disease populations in the country. Dr. Thompson, how does, let me preface this by saying that Dr. Burgess, again, and I have legislation that we're co-sponsoring, H.R. 3884, the Sickle Cell Disease and Other Heritable Blood Disorders Reauthorization Act. So how does the reauthorization of critical cell disease programs ensure that patients have the support and resources that they need?
So the principal benefit of this act really is to the extent that we actually can disseminate the education and training, moving it from our academic medical centers to where the patients are. And so really utilizing the hub and spoke model for actually getting more information, more knowledgeable providers in taking care of sickle cell disease. I should also note, especially from your state of Georgia, that the benefits of actually combining the work that HRSA does with the data collection from the CDC has also been quite helpful. That the Centers for Disease Control started out with 2 states, Georgia and California, and that data from those 2 states has helped to inform, again, better ways to actually identify patients and to treat them.
Great. I'm sorry I don't have long, but you want it? I'll yield to the lady from Washington.
Thank you. I appreciate the gentleman yielding. I just wanted to address the CDC bills. We're considering these specific individual reauthorizations today because they're set to expire. But we also plan on looking at broader CDC authorization and reform this Congress. We must do our job as authorizers to ensure these programs are operating as intended with proper accountability and oversight. CDC has a history of often relying on Section 301 or 317 of the Public Health Service Act, which provides very broad research and grant authorities to continue these programs, even if Congress does not specifically reauthorize them. These authorities were initially crafted in the 1940s and 60s and have built upon further since then. As a part of looking at CDC reform, I think perhaps a good initial step would be to examine the use of these broad authorities and ensure that there's transparency as to when, how, and to what extent they are given, as well as if these authorities are even still necessary at all, given work on smaller programs like the ones they're considering today. Appreciate the gentleman yielding.
And I'll yield back. Thank you, Mr. Chairman.
Gentleman yields back. I now recognize Dr. Schreier. 5 minutes.
Thank you, Dr. Bushon, and thank you to all of our witnesses here today. I wanted to talk about two things today. First is Children's Hospital graduate medical education funding, and the other is direct primary care. I'm going to start, just like so many of my colleagues, just up in arms that this funding would be held hostage for political gains. I'm a pediatrician. My residency training was funded by CHGME. That was at Lucile Packard Children's Hospital at Stanford. And I understand how important that training is and that pediatricians need to be trained in a whole gamut of care and need to be prepared for whomever comes in their office. Children's Hospital GME funding has been reauthorized on a regular basis 5 times in a bipartisan way since 1999, has increased the number of pediatricians available to all of us and our kids. Now, right now, thanks to COVID and a number of other factors, we're facing a shortage of pediatricians and other physicians. This is coming at a time of increased need. We hear a lot of discussion in this committee and elsewhere about children's mental health and increased needs. And it is just unimaginable to me. I mean, frankly, until today's hearing, I could never have thought that this funding would be held up for some sort of political agenda and putting kids who are already bullied and vulnerable right at the center of it. This program needs to be reauthorized in a timely fashion. Children's hospitals depend on it. The Children's Hospital Association has requested a clean authorization. I would like to submit a letter into the record on this specifically from the Children's Hospital Administration.
No objection.
Because healthcare, whether we are talking about women's healthcare or children's healthcare or other training of physicians, this is not something that should be dictated by politicians. I don't have any questions about that particular topic. The other topic is about direct primary care, and I'm excited to see that the Medicaid Primary Care Improvement Act is on the docket today, clarifying that Medicaid can utilize the direct primary care model. This is designed around healthcare, not fee-for-service billing. And the way it works is that patients or Medicaid or insurance companies pay an affordable monthly fee that allows doctors the time they need to just really work on their patients' health. Doctors have a certain number of patients in their panel who they are responsible for providing the best possible care for. A smaller patient population often means that more time can be spent on preventative care, diet, counseling, preventative measures. And it often turns into a better relationship between doctor and patient, fewer visits to the emergency room, and better outcomes. One doctor in my state, Dr. Garrison Bliss, is a pioneer in this effort. He's done it in many different contexts, including Medicaid, was one of the first in Washington state. And he notes that most of his patients are over 60 years old, and none of them died from COVID. And he credits that relationship and close contact and avoidance of ER visits. This model of care just deserves to have more pilots around the country, hopefully with similar results. And I was just going to ask Dr. McNamara, first, thank you for speaking so beautifully about the care of transgender kids. And if you want to add anything or correct the record on that, you are welcome to do that in the remaining minute. But I also wanted to ask you whether this direct primary care model, how that would affect your practice and the relationship you have with your patients.
Thank you, Congresswoman, and it's a pleasure to speak to a fellow pediatrician. Primary care is the foundation of health and wellness in this country. It's a privilege to take part in our primary care system and to see children flourish into adolescents who become my favorite patients. As far as correcting the record, it is difficult to do so in a way that does justice to the amount of misinformation that we have all heard today. I urge this body to deliberate over the extensive documents that have been submitted to the record that debunk this disinformation and misinformation, and to base their decisions on science.
And I will just add in my 10 seconds that I appreciate your noting how much engagement with the patient and the family happens with counselors, psychologists, psychiatrists, physicians, endocrinologists, to make sure that you've got this right and the care that these children and young adults really deserve. I wanted to call attention to that thoroughness and the care that you provide. Thank you. I yield back.
Thank you. The Congresswoman yields back. The chair now recognizes Mr. Crenshaw from Texas for 5 minutes.
Thank you, Mr. Chairman. I first want to thank my friend, Representative Schreier, for her great bipartisan work on the direct primary care bill that we've been working on. It's, look, there's a lot of things we can agree on, and this is certainly one of them. And this is a small step in the right direction. I'm really excited that we're gonna get this through. But now there are some things we disagree on here, and that's what we've been talking about a lot in this hearing. So let's shift focus to the giant elephant in the room. And this is the reauthorization for the Children's Hospital's GME funding. And yes, it's true, this is my bill. And what it does is it withholds funding from these hospitals if they engage in what they call gender affirmation therapy, these physical changes to a child's physiology, permanently disfiguring them through either puberty blockers or even surgical modifications. Now, look, I understand that the other side of the argument here believes they are on the side of compassion, and maybe that's a sincerely held belief. It is just as true that I believe we are on the side of compassion. I think it is indeed compassionate to stop kids from being permanently physically altered based on little to no evidence that it will improve their underlying mental condition. Now, why is this controversial? That's actually beyond me. Not too long ago, I think we all agreed that performing double mastectomies on a 12-year-old girl was wrong. Now it's become a political movement where radical activists have bullied mainstream medical associations and members of Congress into repeating this propaganda. Now, it should be noted that in the public, this subject is actually not very controversial. In fact, a recent poll just last month by the Washington Post showed that 68% of Americans opposed using puberty blockers on children. That's just a question about puberty blockers. Imagine if the question had been about castration or surgical interventions. So you've got to convince me that 70% of Americans are just a bunch of fools that refuse to accept the so-called science. Or maybe, look, I have another theory. Maybe they have a very baseline understanding of ethics and common sense, which tells us that maybe, just maybe, it's a bad idea to submit children to permanent life-altering medical interventions based solely on a temporary ideation about their gender. Gender affirmation is not science, and there's no evidence-based standard of care. To say that is a lie, or is at best redefining the term evidence-based. What this is a social contagion. It is based in pseudoscience and radical ideologies. And it's sweeping across our country and encouraging children to make irreversible changes to their gender. What's worse, it's coming from adults and institutions who know better, to include our children's hospitals, and institutions that are supposed to be tethered to sound science and their Hippocratic oath of do no harm. Now, maybe I'm an optimist, but I do believe that science and evidence will win out in the end. And in the future, we will look back at these gender-affirming therapies as we now look at lobotomies and electroshock therapies. I have some reason to be hopeful. Notably, Great Britain's National Health Service restricted these clinical interventions for minors just last week. Reviews published in the British Journal of Medicine, the Journal of the Endocrine Society, even in the American Academy of Pediatrics, all cite the lack of evidence. I'm going to submit for the record this review published in the Journal of Endocrine Society that found that there is, quote, low-quality evidence for the idea that hormonal treatment improves quality of life, depression, and anxiety among adolescents. Now, here's the important part. This was a systematic review, which by definition is not cherry-picked data, but it's an all-encompassing review of all the data. It has thoroughly debunked the notion that any of these treatments are, quote, evidence-based, let alone recognized as, quote, standard care. My colleagues are using these terms not as accurate representations of the data, but as propaganda. Now, this funding program is reauthorized every 5 years. It provides taxpayer funds to train resident physicians at children's hospitals across the country. It's true, it's been a bipartisan funding mechanism for years. Let's keep in mind something, though. This is taxpayer money. And when 70% of taxpayers oppose these barbaric treatments on minors,
then taxpayer money should not fund it. That's why I'm stipulating that as part of this reauthorization, we will not provide any funding through this program to children's hospitals that push gender transition on minors through puberty blockers, hormone therapies, and surgeries. Let's be clear, because there's another lie that's been told. It does not prevent any mental health therapies at all. Despite these lies being told, it does not prevent those kind of therapies at all. This is the issue of our time. This is a hill we're going to die on. It's too important. It's too important to protect our kids from this. In my very limited time, I have too much limited time, so I'll wait for my colleagues to yield to me to ask questions, and I yield back. Thank you, Madam Chair, or Mr. Chairman.
Gentleman yields back, and the chair recognizes, you have anyone? Dr. Joyce, you're recognized for 5 minutes.
Thank you for yielding, Mr. Chairman, and to our witnesses for appearing here today. I think there is some subjects that we can agree on. Innovation in healthcare is critical for producing better outcomes and improving the quality of care that patients receive. That is why I, like many others on this panel, are very concerned over the impact that the Inflation Reduction Act is having and will continue to have on future development of new treatments and new cures. It's been 40 years since the Orphan Drug Act was signed into law, and I'm quite worried that the new misguided law will undermine one of the greatest incentives that we have seen, which has led to the development of over 600 novel therapies and cures for diseases. However, there's still much work to be done. There are over 10,000 rare diseases, 95% of which lack an FDA-approved treatment. As enacted, the IRA disincentivizes post-approval research and development and seeks additional indications for promising treatments. This will acutely impact pediatric patients, who by their nature make up a much smaller subset of the total population. Dr. Thompson, thank you for being here from CHOP in Philadelphia. Is a decline in the research and development investment in pediatric research a concern? And what impact will that have long-term on the patients that you treat each and every day?
Thank you, Dr. Joyce. I think that there are some phenomenal opportunities to continue to make progress, not only in pediatric health, but also in the health of Americans overall, when we have the opportunity to intervene, to diagnose children and to treat them, largely coming from innovation. The ability to incentivize manufacturers to continue to stay in this space for rare diseases has been extraordinarily helpful. There have been challenges with the continuum to determining what will actually be paid for in terms of insurers. And I do think that that continues to be something that we need to be very mindful of, because it is not entirely clear that the incentives that are there to manufacture the drugs are being paralleled with incentives to actually cover them in the clinical space.
Dr. Thompson, programs like sickle cell disease and other heritable blood disorders, Research, Surveillance, Prevention, and Treatment Act help bring much needed hope to the rare disease patient communities and help spur the research and development that will add new and improved treatments for these rare diseases. How can the lessons that we have learned from this program be used to support research and treatment for other rare diseases?
I think that the rare disease community is energized and is quite unified in trying to continue to learn from each other on how we can best go about that. Some of them are private-public partnerships. There certainly are a number of nonprofits that have been very active, especially family foundations, in bringing some of these things to our attention, encouraging science and following the science, and looking at ways to bring innovation from the bench to the bedside is, I believe, one of the things that many of our academic medical centers do quite well. I think without taking full advantage of the innovations, the breakthroughs that are occurring in sickle cell disease, if we don't take advantage of those in this patient population, it really does send a message to those who are suffering from other more rare diseases. And so I think embracing this in sickle cell should be a very positive message to all.
Thank you for that insight. Dr. Thompson, in the past few years alone, there have been a number of new innovations in the cell and gene therapy space to cure hematologic diseases. Dr. Thompson, can you speak to how impactful curative therapies for diseases could be for the patients that you treat, and the impact that they have on their life to be cured of these diseases.
It's been absolutely extraordinary, and I've had the privilege of being part of the gene therapy efforts over the last 10 to 15 years in the hemoglobinopathy space. It's done two things. It's certainly for the individual patients who have been successful, it's been transformational. These are individuals who can now complete their educations, raise their families, maintain full employment, and can really live their best lives. And so for the individuals, without question. For me, it's also been a very hopeful one because many of these diseases are now diagnosed by newborn screening. And while I think in the past, many of these families were devastated when they thought that they were bringing home a perfectly healthy infant, yet to be told 2 weeks later that their child screened positive for something, gene therapy that's being used right now in adults gives them tremendous hope that their children can not only live long lifespans, but can hopefully leave lifespans with far less disability than they would have in the past.
I think we can all conclude that innovation must be maintained and must be maintained as one of the cornerstones of American medical treatment. Thank you again, Dr. Thompson, and Mr. Chairman, I yield.
Thank you. The gentleman yields back. The chair now recognizes the gentlewoman from Massachusetts, Ms. Tran, for 5 minutes.
I thank the chair. I'm grateful to all the witnesses who came today, prepared to talk about the bipartisan public health bills that are being covered in the hearing. We desperately need to advance proposals to address firefighter cancer rates, end Parkinson's, tackle the maternal health crisis, and so much more. But like so many of my colleagues, I'm disappointed that the legislation focused on critical funding for our children's hospitals, and that's the one that's being politicized, which is why so many of the moms on this committee are speaking up. There are 59 children's hospitals who receive funding for graduate medical education from CHGME, just 1% of all hospitals in the country. But together they train more than half of our pediatricians and pediatric specialists across the country. Boston Children's Hospital in my home state is home to one of those training programs. In fact, the training program at Boston Children's receives no funding through Medicare, meaning it relies solely on CHGME funds to support their work with interns, residents, and fellows. The team at Boston Children's works around the clock to serve the children who travel from all over the country for specialized care. They deserve to feel supported by those of us in positions of power, not like that they're pawns in a political game. Pediatric providers are training, learning, and making contributions to advance and promote high quality and effective care and treatment that every single one of us would want for our own child if it was ever needed. Dr. McNamara, what are some of the challenges the pediatric care workforce is facing? And can you give us examples of the specialized care that would be disrupted if a partisan battle over reauthorization of CHGME continues?
So, children need us more than ever. They have more complex health needs and mental health needs than they ever have. Part of that is because we're very good at providing advanced care that we've been developing over the years, and part of it is because of the current post-pandemic climate. The examples of care that would be affected would be care for congenital heart disease, intensive care for sick kids, sick neonates, routine well care, dentistry. I could go on.
I appreciate that. Boston Children's Hospital is home to the first pediatric and adolescent transgender health program in the United States. However, misinformation has repeatedly spread online suggesting the hospital performed gender-affirming genital surgeries on young children, when in reality, surgeries are only performed on consenting adults. But that hasn't stopped healthcare workers at Boston Children's from being subjected to threats and attacks. Threats and attacks, by the way, that are a direct result of a coordinated campaign designed to, and I'm quoting a conservative political action conference speaker here, eradicate transgenderism. And by inviting a witness to elevate that dangerous rhetoric in the United States Congress, the majority is allowing a target to be painted on the backs of some of our nation's most vulnerable children and the healthcare professionals they rely on. Dr. McNamara, can you speak to the dangers of increased threats and attacks on our nation's pediatric healthcare professionals, and do you think this intimidation undermines their ability to recruit specialists or continue providing a high level of care?
I absolutely do. I think if I was a medical student looking at the current political climate, it would feel overwhelming.
I appreciate your candor, Doctor. Time and time again, I've heard my colleagues across the aisle discuss the urgent need to address the youth mental health crisis. But we can't do that if we ignore the fact that trans youth are suffering higher rates of mental illness, higher rates of suicide ideation, and higher rates of self-harm, a problem with a large body of medical literature demonstrating that with support at home, in school, and in communities, coupled with access to gender-affirming care, trans youth do as well on mental health measures as their cisgender peers. We should be working to increase access to health care for all of our children, not to restrict the ability of children to define and express themselves. A ban on gender-affirming care is dangerous, it's misguided, and it's cruel. And it's a shame that Republicans are using what should be a bipartisan piece of legislation to contribute to the dangerous attack on our most vulnerable children. They deserve better. I yield back.
The gentlelady yields back. The chair now recognizes Dr. Dunn for 5 minutes for questions.
Thank you, Mr. Chairman. I appreciate the hard work this committee is putting in to ensure that critical public health programs do not lapse this year. I'm pleased with the level of bipartisan collaboration shown to ensure that the programs that are aimed at improving childhood and maternal health serve our most vulnerable constituents. We're also supporting research to fight rare diseases. I do want to take a moment to echo the comments of my colleague, Dr. Burgess, regarding the Children's Hospital GME program. I appreciate the bill put forth by my colleague, Mr. Crenshaw, to protect children from harmful gender-improving care and hormone therapy. And I understand that many children may feel immense peer pressure and psychological distress for many different reasons. These children need loving, caring, parental involvement. They need emotional support, and they need highly specialized medical experts with their best interests at heart. It's a monumental decision to undertake gender transition surgery on a potentially fertile person. The radical race to embrace gender transition is undoubtedly harming some of our children. When considering pediatric GME, it's critical that we strike the right balance between banning appropriate treatments and procedures and properly equipping physicians with the skills and the knowledge they need to perform complex surgeries and inform the choices that patients and parents make. There actually are unique cases in which a baby is born with genetic disorders that cause truly ambiguous genitalia. This is a mix of male and female reproductive organs. As a urologist, I'm very familiar with such cases. Medical and surgical interventions may be needed to mitigate harmful side effects and even to save lives. In these cases, it's important that pediatric urologists have the specialized knowledge and the proper skill sets to make the best decisions with the patients, with the consent of their parents. I actually do not have any questions, Mr. Chairman. I'm willing to yield time to anybody on the panel. Mr. Crenshaw, I recognize you.
Thank you, my colleague. Thank you to my colleague, and I do have a few questions. You know, I want to say a few things first. We keep hearing this is a politicized issue. This is a manufactured culture war. I got to say, we aren't the ones who did that. We aren't the ones that came up with this radical new movement that is performing permanent physiological changes to children with no evidence of any benefits. We didn't start that. We're just trying to stop it because it's crazy. It's a contentious issue, which almost 70% of Americans oppose. So we are just saying here that taxpayer money shouldn't be used for it. That's all. This should not be that controversial of an issue. Questions are for Dr. McNamara. I just want to ask you, honestly, you're not concerned about the unknown effects of puberty blockers, hormones, and surgical interventions in kids, the long-term effects, not concerned about that?
Everything I've said here today comes from a place of deep honesty and conviction for the care that I provide and the community that I'm a part of.
You've said that we've cherry-picked data. How do you mean how do you mean that?
So it is very unscientific and flawed to pick a single study or a single statistic and to discuss it in isolation.
Totally agree.
Medical experts are able to talk about all of the evidence as a whole.
Totally agree. So it's good to look at systematic reviews, right? That's the gold standard of evidence when you're trying to understand whether something works or whether it doesn't. So the British Journal of Medicine looked at 61 systematic reviews with the conclusion that, quote, there is great uncertainty about the effects of puberty blockers, cross-sex hormones, and surgeries in young people. The Journal of Endocrine Society came up with the same conclusion, even the American Academy of Pediatrics. They all cite the lack of evidence. And so here's the thing. If you're doing a therapy, and it's, temporary, whatever, fine, maybe let's try it, let's see if it works. But when you're talking about permanent physiological changes, do you not agree, just from an ethical standpoint, that you might want extremely strong evidence of the benefits? And there is no systematic review that states that there is strong evidence of benefits.
Sir, are you aware of how the quality evidence grading system works and how it's applied?
Yeah, we've read through it. That's why I'm citing these journals. So which journal says something different? We should have that debate. Tell me a journal that has done systematic reviews that cites different evidence, that cites strong evidence for benefits of these therapies.
The standards of care were developed based on extensive.
You're not telling me any journal, you're not telling me any study. Don't say
That's not
standards
what
of care.
Yeah. So.
Tell me one.
The standards of care.
That's the standards of care.
Yes, the
That's
standards of
not
care.
a journal, that's not a study. That's not an organization, that's not an institution. You're just saying words. Name one study.
Yeah.
I'm out of time. I yield
The
back.
gentleman's time has expired. Mr. Dunn yields back. The chair now recognizes Dr. Miller Meeks for 5 minutes for questions.
Thank you, Mr. Chair, and I thank our witnesses for being here and testifying before the committee today. I'm proud to see my bill, H.R. 3226, PREEMIE Reauthorization Act, included in today's hearing, and I thank Ranking Member Eshoo as well as Representatives Kelly, Blunt, Rochester, Burgess, and Kiggins for their hard work on the legislation. As a mother and a physician, I understand the harmful health implications of preterm birth and recognize the importance of public health programs like PREEMIE, which seek to address the root causes, also because I was the director of the Department of Public Health. In 2021, Iowa mothers gave birth to almost 3,700 preterm babies, which represented 10% of all births in the state that year. Not only do preterm births pose great health risks to the mother and her baby, but they are very costly to the healthcare system, as was alluded. Over 28% of infant deaths are preterm related, and the average cost associated with preterm births in Iowa is $58,000. Dr. Shiro, in your written testimony, you state that almost 2/3 of pregnancy-related deaths are preventable, and that preterm birth rates worsened in 38 states between 2018 and 2019. Can you please explain how reauthorizing PREEMIE will help reduce those rates and how funding will be used?
So first, the financial impact of preterm birth on the U.S. economy and families. Medicaid pays for 40% of all deliveries, and an estimated 40% of medical costs associated with preterm birth has a significant impact on both federal and state budgets. What we are trying to advocate for here is more research to go into more solutions that will solve for the preterm problem in this country that you just alluded to or highlighted and have dealt with in the neonatal intensive cares across this country. And the point of this is to be able to collect that data to translate those into real actions.
Thank you. I'd also like to speak in support of Congressman Crenshaw's legislation to reauthorize Children's Hospital GME. The Republicans wish to reauthorize this. It's the parties on the other side of the aisle that wish not to. I know firsthand that a physician's training is a lengthy and expensive process, which is why renewing CHGME to ensure that there is sufficient supply of pediatricians to meet demand is so important. The timely reauthorization of this program through 2028 will continue a legacy of over 20 years of supporting our healthcare providers. However, I'm also supportive of a ban on funding for hospitals that furnish puberty blockers, hormone therapies, and surgeries for the purpose of altering biological genitalia to minors. So, Dr. McNamara, is an XY chromosome assigned at birth?
I'm sorry, I don't understand the nature of your question.
Simple question. Is an XY chromosome assigned at birth?
We often don't do routine chromosome testing on infants.
So an XY chromosome would not be assigned at birth, nor would an XX chromosome, although you say that sex is assigned at birth. There's a lack of scientific evidence regarding the effectiveness of these medical interventions, especially among minors, which is why countries in Europe, such as Denmark, Britain, Sweden, have described treatments as experimental and are urging doctors to proceed with caution and why they've changed their guidance. The purpose of healthcare is to treat and heal, and it's not of interest at the expense of physical and mental well-being of patients. What evidence, Dr. Grossman, do we have that the thriving Dr. McNamara talks about is because of hormones or surgery and psychotherapy, family support, regression to the mean, placebo effect, or some other confounding variable? After all, there have been no randomized controlled trials. Have there been randomized controlled trials, Dr.
There
McNamara?
have not. Randomized controlled trials are what are the gold standards, that gold standard, that is what we're always looking for in medicine. We do not have those kind of studies. As you said, there are variables, confounding variables that can interfere. If a child is going through these gender-affirming cares, so-called, the child may also be getting psychotherapy. The family may be getting support. How do we know that the improvement on the other side is due to the hormones or the surgeries or the psychological support?
Yeah, thank you. And I think to say that the federal government is not already involved in healthcare is either naive or disingenuous. We saw that throughout the pandemic, that federal and state governments were both involved in the doctor-patient relationship. As a veteran, I defended the constitutional rights of Americans. As a doctor, I swore to do no harm. Because I care about the physical and mental health of your children as much as I do my own
Thanks.
children, I support restricting federal funding for experimental care that is permanent and
Gentlelady's
irreversible
time's
in minors.
expired.
Thank you. I yield my time.
The chair now recognizes Mr. Pence for 5 minutes.
Thank you, Chairman Guthrie and Ranking Member Eshoo. I'd like to speak in support of the Action for Dental Health Care Act of 2023. Across my district, dental professionals continually communicate to me the impacts they are feeling from workforce shortages. Healthcare facilities, including dental practices, are struggling to maintain existing staff and rising salaries, let alone find enough qualified individuals to fill open positions. Universities are also straining to maintain the necessary pipeline of our next generation's health professionals. As we look to reauthorize dental workforce programs through the Action for Dental Health Act, it's important we ensure HHS is prepared to support the growing demand for dental professionals across the country and my Hoosier state. I'd like now to yield the rest of my time to my colleague, Congressman Crenshaw, a champion for our young children.
I thank the gentleman, and look, I just want to make a few more points, and I want to run everyone through this thought experiment. So you know, my daughter's going to grow up with a father with one eye, and at some point she might say, you know, I want one eye, right? I identify as somebody with one eyeball, which, by the way, is far less important than your gender, just physiologically speaking. And so if I take her to the doctor and I say, can you just enucleate that eye for us because she identifies as a one eye, she wants to be just like her dad. What would the doctor say? They'd say, you're crazy and I'm going to have you arrested. That's what they should say. And this is for a physiological intervention that is far less important than your actual gender and your reproductive organs. Like, we have to stop this madness. This has gone too far. You know, I asked before about what evidence is there that there is benefit for these so-called standards of care. I mean, anyone can say that they have a standard of care, but it has to be based on some kind of evidence and research. And when you've done systematic reviews, which is, again, is the gold standard for how you come to a conclusion within the scientific community, systematic reviews of 61 other systematic reviews, and you find little to no evidence that there's benefits for this, maybe you just press pause. Maybe you just press pause. Because if we're doing permanent physiological interventions to children that have permanently disfiguring them for some hope of a benefit that is not conclusive, then maybe we should press pause. Like, that's all we're saying. Press pause. And actually, that actually is even less than that. All we're saying is let's not put taxpayer money toward it. Right? This is no different than how this Congress deals with the Hyde Amendment. This is a controversial issue. Abortion is a controversial issue. And so we say, look, we disagree on this, so let's make sure we don't put taxpayer funding toward it. That's all this bill is. Let's not put taxpayer funding towards something that is so obviously unproven and contentious. Actually, I don't even think it's really not that contentious. 70% of Americans oppose it. So it's actually, the American people are pretty much on the side of not doing this, or at least pressing the pause button. Dr. Grossman, you're a child psychiatrist. Can you expand upon the profound lack of clinical reviews and the long-term impacts of these treatments, puberty blockers, hormones, and surgeries?
Well, yes, as I said, we don't have the kind of studies that we would like. And I think it's very important for people to understand that when we talk about standards of care and we talk about guidelines and all the various associations that have come out for gender-affirming care and about politics and partisanshipness, those organizations themselves are rife with politics. They are permeated with politics.
Can you expand on that? Tell us how those activists have pressured dissenting voices in this
Well, yes,
field.
I just interviewed a number of doctors for my book, pediatricians, endocrinologists, who reported back to me on the fact that when they tried to speak up and have panel discussions or presentations that challenged gender-affirming care at the American Academy of Pediatrics or at the Endocrine Society, they're simply not given that opportunity. Even people, you know, who have written, writing articles, the articles are turned down by a lot of journals. People have to understand that politics medicine, unfortunately, is permeated with politics at this point. Now, ideally, we wouldn't be stepping in. Who wants the government stepping in between doctors and parents and children? Of course, we ideally don't want that. But when there's something that is so wrong that's going on, then I think we have to.
Thank you, and I yield back to Mr. Pence.
Yeah, Mr. Pence yields back. The chair now recognizes, seeing that all members of the subcommittee have been recognized, the chair has now recognized Ms. Schakowsky for 5 minutes for questions.
Thank you for allowing me to wave on to this, to the subcommittee. I just want to briefly begin by talking about Children's Hospital, the medical education programs for children's hospitals. In Chicago, have Lurie Children's Hospital, which is such a fabulous institution, the largest medical provider in Illinois. But is very concerned because of the disparity between what is given to other hospitals and the children's teaching hospitals. And I just wanted to mention that because we do rely so much on that. But I really now feel obligated, and it's a privilege to now talk about, as the only parent, I think, in this room, or grandparent of a trans young man, someone whose life has been enormously improved because of his ability, born as a girl, but finding his true self now as a young man who is living the life that belongs to him. He is now graduated from college. He is teaching school. He is living with his girlfriend, and fortunately in a place where he has the opportunities to get the care that he needs and has throughout the period that he needed it. And so, Dr. McNamara, I want to thank you, first of all, for your voice. And I wondered if you could just enumerate some of the other falsehoods that we are hearing and that I have experienced now in my family's lifetime.
Thank you. So first of all, regarding standards of care, that is not just a casual term. The standards of care that outline how gender-affirming care should proceed for people of all ages, including adolescents, have been published in reputable journals. The Journal of the Endocrine Society has published their extensively vetted guidelines, which they have issued several times after re-examining the evidence. The World Professional Association for Transgender Health issued the 8th edition of the Standards of Care, which is based on peer review of hundreds of global experts who basically performed systematic reviews in partnership with Johns Hopkins. The AAP has also issued statements that issue kind of practice guidelines that are taken very seriously in our community. Now, I want to address the low-quality evidence argument that comes up a lot, and it's critical that we all understand here today that that is a technical term, and that when it's used for public consumption, it can be quite confusing. There are ways to grade evidence using a very specific rubric where the number of study participants, the length of follow-up, et cetera, is assessed. In medicine, we recognize that all clinical care is different, all clinical research is different, and the practicalities of conducting studies are different. Low-quality evidence means that there is a basis of evidence, and it often informs strong recommendations for care.
Thank you for that. And I also want to see if you could actually help us understand the kind of work that is done with families. You would think that these children are snatched away and taken someplace and done, but isn't there a whole process that patients and their families go through? And if you could tell us about that.
Yes, ma'am. Well, oftentimes, the care begins with long conversations that take place over months and months, where families hear about all of their options. Parents hear about the risks and the benefits. They hear about various options. They ask lots of questions, and the young person gets mental health support.
And finally, let me just say, if you could speak to the importance of having both behavioral health care and also the medical needs of these kids, how both are so important. It's implied that it's only, the...
Gender dysphoria is real, and it needs to be diagnosed by a specialist. That is the standard of care in this country. Medical care does not proceed unless a mental health specialist has diagnosed this condition.
Thank you.
Thank you.
I yield back.
Gentlelady's time has expired and yields back. The gentleman from New York is recognized for 5 minutes.
Thank you, Mr. Chair. I thank you and our ranking member Eshu for the opportunity to wave on. I thank you for including the National Plan to End Parkinson's Act as a part of this hearing. In Congress, I have made helping those with neurological disorders one of my top priorities. I've long led efforts related to the other top neurological disorder facing Americans, which is Alzheimer's. I'm proud to expand my championship to facing Parkinson's as well. Currently, more than 1 million people in the U.S. live with Parkinson's disease, and there are no treatments to cure, prevent, or significantly slow down its progression. Parkinson's is the second most common neurological disease and is unfortunately growing and growing fast. Nearly 60,000 Americans are diagnosed every year, and the disease is estimated to cost the U.S. $52 billion annually. With the number of Americans diagnosed with Parkinson's disease expected to increase as the population ages, the cost to the U.S. economy is also expected to balloon to nearly $80 billion every year by 2037. I thank my good friend and colleague Gus Bilrakis for working on the National Plan to End Parkinson's Act with me. It's an honor to work with him on this, and I know how much it means to him personally, and I thank him for the relentless work as we work together to push this forward. Our bipartisan, no-cost legislation will, for the first time, unite the federal government in a mission to cure and prevent Parkinson's, alleviate financial and health burdens on American families, and reduce government spending over time. This pioneering legislation is greatly needed. I also thank Mr. George Manahan for joining us here today and bravely sharing your journey with Parkinson's. By speaking here today, you do give a face to Parkinson's. As Mr. Manahan noted, we all know someone with this devastating disease. I first learned about Parkinson's from a friend who suffered with it, and recently my good friend and colleague, Congresswoman Jennifer Wexton, was diagnosed with Parkinson's. I thank the Congresswoman for showing another face of Parkinson's and bravely sharing publicly her journey. With that in mind, I would like to share a brief message from Congresswoman Wexton, and I quote, "As many of you know, earlier this year on World Parkinson's Disease Day, I shared that I myself have been diagnosed with Parkinson's disease, or PD. Over the past several months, I have been touched by the hundreds of messages of appreciation and hope that I've received from people who suffer from PD, but even more often from their loved ones and caregivers. A diagnosis of Parkinson's disease affects not only those of us who suffer from the disease itself, but all of the many people in our lives who love us and want us to be well again. Parkinson's is the fastest growing brain disease worldwide and is estimated to affect at least 14 million people by 2040. PD is a progressive neurodegenerative disease, and although there are things we can do to slow its progression At this time, there is no cure. Eventually, many of us who have Parkinson's will be unable to walk, talk, or even feed ourselves. We will require extensive and expensive institutional or in-home care, the cost of which will likely be borne primarily by U.S. taxpayers. Research has shown that although heritability is a factor, PD is largely caused by environmental toxins, and it can therefore be prevented if adequate precautions are taken. In addition, great strides are being made to identify genetic markers of Parkinson's, which we believe will lead to identifying variations of PD that will allow researchers to develop targeted treatments that will help alleviate symptoms and improve quality of life for those with the disease and slow or even halt its progression. By bringing together key stakeholders to build a national plan to prevent and cure Parkinson's, this bill is taking a critical and historic step for the millions of Americans with Parkinson's and their families, just like mine. I urge you to advance this critical bipartisan legislation, and I end there with Jennifer's quote. I could not agree more. I understand that receiving a Parkinson's diagnosis is truly devastating for individuals and their loved ones. It is incumbent upon Congress to ensure Americans know they will be supported during this frightening and life-altering time. Our legislation does just that. My hope is that this bill, when signed into law, will do for Parkinson's what the National Plan did for Alzheimer's and bring together coordination, care, and research, all to help those with Parkinson's as well as their loved ones. So to Mr. Manahan, I again thank you and ask, what would this legislation mean for those living with Parkinson's? What about their families and their friends?
It would give us hope. And really, we haven't had hope until just recently. We have found a biomarker which can detect Parkinson's disease at a very early stage. So, you know, for those people who are left who have Parkinson's, this would give us hope that we can find a solution working together hand in hand.
And I would think the investment and coordination factors of the legislation would provide for more effective treatments.
Yes.
Thank you.
Sorry.
With that, I yield back.
Thank you. The gentleman, thank you. Absolutely. The gentleman yields back. The chair now recognizes Ms. Barragan from California for 5 minutes.
Thank you, Mr. Chairman. I want to echo some of my colleagues' comments about the importance of the Children's Graduate Medical Education Program and how critical it is. I was recently in my congressional district where I had an opportunity to meet with Long Beach Memorial Care to hear about the importance that it has and why we need to continue to support it and fund it. I am highly disappointed in my colleagues across the aisle who are basically holding this bill hostage and this funding hostage by, putting in provisions that are just unacceptable. And so it's really unfortunate. And I just wanted to echo that concern that we continue to work to get this funded and taking out some of these harmful provisions. I want to kind of follow up on my colleague, Representative Tonko, Mr. Monahan. I found your testimony to be very powerful, particularly on your optimism that we can develop a national plan to end Parkinson's disease. I agree we need to use every available resource to fight Parkinson's disease. It's costing patients their lives and significantly increasing our health care costs with an estimated $52 billion in direct and indirect costs to society. And now that we have an accurate biomarker that can detect Parkinson's disease before the first symptoms appear, innovation is urgently needed to find a cure. Now, as my colleague said, we all know somebody who has Parkinson's. My father had Parkinson's for most of my youth. My father died when I was 23 years old, and for most of my memory, he was shaking. And I would have to sit next to him and hold his hand or try to hold his arms because I wanted the shaking to stop. I didn't know any better. I was a kid, and he and I, we watched baseball games together. And so it's been a personal issue for me and something I know we need to continue to champion. That's why I'm a strong supporter of H.R. 2365, the National Plan to End Parkinson's Act, which will create an advisory council to prevent and cure Parkinson's. In your testimony, you speak about the lack of services available for people with Parkinson's. How can the federal government support efforts to build out a stronger public health and caregiving infrastructure to support patients and families living with Parkinson's disease?
Well, it's interesting you mentioned that because, you know, unlike Alzheimer's, we don't have Parkinson's services on a state-by-state basis. So when I was diagnosed, I didn't know anybody with Parkinson's, and there was no support groups. So we started those in West Virginia. We started a 5K that raised money for the Michael J. Fox Foundation. We raised $500,000. We support groups, free exercise classes. So we did it ourselves. But there has to be a way that state by state, there has to be some continuity of care and continuity of support.
Right. Well, thank you for your advocacy, for starting the support group. When I remember when Michael J. Fox came out with his diagnosis, I thought, you know, oh, this is going to be some hope. There's going to be a foundation that's going to invest in this, but certainly they can't do it alone. And so it's critical that Congress also to help out. And so I want to thank my colleagues who are working on that issue. I want to turn to maternal health. Dr. Sherritt, would you please explain how maternal mortality review committees align and or collaborate with perinatal quality collaboratives to identify opportunities to prevent pregnancy-related deaths?
Sure. Happy to, and I would say that California PRQ is a big success story, especially around preterm birth, and March of Dimes has been collaborating with them with some time. Fundamentally, the PQCs do the work. And so what they do are state or multi-state. What they tend to do are their networks that improve quality and outcomes. So they have multiple stakeholders, whether it's clinicians, hospitals, communities that work together, and fundamentally take what the the recommendations from the committees that, I can't remember, now I'm so tired by the end of the day, MMRCs, they take that and fundamentally drive the best outcomes, right? So they take the data, turn around and say, this is what we would recommend, and do the hard work.
Great. Thank you so much. With that, I yield back.
Thank you. Thank you so much. And so many of us have families come tell their stories to us, and it's so powerful to hear stories. And thanks for sharing, because Congress is made up of America, and so we have the same stories moving, so it's important to do. Well, thanks. That's concluded all of our members and people who've waved on that would like to ask questions. Thanks for your testimony, your willingness to sit here so long and answer so many questions, and it's important, and it informs our work, and we really appreciate the opportunity for all of you to be here today. To do a little committee business, we have a list of, and actually was Representative Wexton's statement was read from, but she had submitted that for the record too, so it's part of it as well. But I issue unanimous consent to insert in the record the documents included on the staff hearing documents list have been reviewed by both sides. Seeing no objection, that will be in order. Again, and thanks so much. And there will be other questions. I know y'all sat here for a long time. There could be other questions that members could submit.
Can I just add something?
Yeah, yes.
Yeah, I would just like to, Mr. Manahan, you're the only one that I didn't get to speak to. Thank you. Thank you to each one of you. Whether I agree or disagree, this is an important place. It's the people's house. And Mr. Manahan, I want to add to your envelope of hope, because the Congress did, in the last session, toward the end of the session, pass legislation creating a new, very small limber agency that is designed to take on the death sentences of diseases. And Parkinson's is one of them. So I want you to know that, there are a lot of members that poured their hearts and souls into that, understanding, that if it's pancreatic cancer, it's a death sentence. If it's Parkinson's, if it's, the cancers. So I just wanted to share that with you. So thank you for being here. You're very courageous. You're very courageous. And Kevin, I'm going to write the question to you. I can't believe that we did legislation, it became law, and the CDC didn't do a damn thing with it for almost 5 years, and now we're reauthorizing it. Go figure.
We're going to have
Ladies, thank
oversight
you.
of that, I can
Yes,
guarantee you that.
yeah,
Thank you so
good.
much, so I
Okay.
appreciate it. But there will be written questions. I'll remind all the members that they have 10 business days to submit questions for the record, and I ask the witnesses to respond promptly. Members should submit their questions by the close of business on June 28th. Again, thank you for your patience. We appreciate you being here, and the subcommittee is adjourned.